last mile happen. So please, that's one of the key areas we want to look at today. The agenda is there, so I will not go through it. I will just mention a few things about the agenda. We have started a bit late. We started at 9. We were hoping to start at 8:30, but we hope we will catch up with time. So for us to keep time, maybe we can get 2 timekeepers because we will hear a lot of presentations and we want to keep everyone on time. Could we get volunteers to keep time for us? We will tell you, we'll give you the instructions on how to watch the time. We can get one from this end and another one from this end. Volunteers, someone with a watch or a phone that has a stop clock. I have some friends in this room who I can volunteer them without fear. Do I volunteer them? No, I want you to volunteer yourself. Dr. Masibo is reading the agenda like it's a thesis. He will help us keep time on that corner. Thank you, Dr. Masibo, for being volunteered. On this side, can we get a volunteer, please? Yes, Mr. Ahmed. Mr. Ahmed will keep time for us on this side. Thank you very much. So those will be our timekeepers. So when we start the presentations, just watch the clock. Yeah, when a county is presenting, they need only 5 minutes to present. When they exceed their 5 minutes, please show them a card that says time up so that we keep to time. We will also try as much as possible to keep to time so that we don't leave here very late. So thank you very much. With that preamble, I would like to welcome my colleague, Mr. Amos Chwer, who will welcome the National Ministry and other partners, and then move us along the agenda. Thank you.
Thank you very much, Judith, and welcome all of us to this meeting. We are cognizant to the fact that we are many of us here, and we come from close to 9 counties, including the national MOH, and of course, partners who are here with us. Kindly feel most welcome to this meeting. So my task here is to try to let us know who is in this room. I know during the past session, we have been working on the slogan here together. We have known each other, but let us know who is coming from where. To start with, may I request the guys from the national MOH, please, to stand up so that we get to know you. National MOH minus Dr. Salim, please. The rest of you could stand up. National MOH. National, where is Joseph? National MOH, please. Could we have the mic so that we can know who is here, who is represented from the National MOH, starting from that side? Are you able to talk loud enough, sir? Introduce yourself and tell us where you are coming from. Thank you, Ernest Sommer from the National Vaccines and Immunization Program. We come to you, Daktari.
Morning. Let me remove my mask so I can remember me. I'm Tracy Njonjo. I work with the Ministry of Health. I'm a pharmacist in the Division of Health Products and Technologies.
Thank you very much, Daktari. Who else? There, Joseph, over there. Who else from the national government? Maybe you can speak later, Daktari. Partners that who are here, either from the national level or supporting us at the county levels, please. Partners. Yeah, you can introduce yourself, please. Thank you.
My name is Anthony Okoth from Africa Resource Center, the regional director.
Thank you, Anthony, and feel most welcome. Who else is here? Partners over there.
Morning, everyone. My name is Samuel Okumu. I'm a projects officer with Amref Health Africa in Kenya.
Thank you, Amref. Thank you very much. Then we move to the counties. I know majority of us come from the county governments. Could we request the county, the host county, Nairobi, to stand up and maybe one of you introduces the rest of the team. Nairobi, our host, we are happy to stay in your county. Yeah, please introduce yourselves.
Hamjambo. Karibuni sana, Nairobi hakuna matata. So I'm Dr. Nora Maore. I'm the Deputy County Pharmacist in Nairobi, NMS now. And with me is Buabi Beatrice from NMS in the Department of QI. The county director will be coming, and there's another person we're expecting. So when they come, they can introduce themselves. Karibuni sana.
Thank you, Dr. And make sure we are safe within your county. We move to Samburu County. Are we here? Over there, yes. Samburu. You will introduce your team.
Good morning. Yes, my name is Mungai Alex. I'm the county pharmacist for Samburu. My colleagues, I believe, are on the way. Yo Samburu hakuna lami. So, na kuna matata huko kidogo. A bit of skirmishes, bandits, but all in all, kazi iendelee. So I think when my colleagues come, they'll introduce themselves. Thank you.
Thank you very much, Samburu. I hope your team will be able to join us. Could we give it to Nyeri next?
Ladies and gentlemen, my name is John Goya, pharmacist in the Nyeri County Department of Health Services.
Introduce your colleague also.
Oh, he's
Yes.
Pratik Mwangi, a farm tech, Nyeri County as well, and he's based in the what we call the county store.
The county store.
The store that replenishes all other facilities, like the buffer store, so to speak.
Thank you very much, Nyeri team, and feel most welcome. Introduce the rest.
Oh,
Okay. Why? How
I
can
think
you
I was
introduce one
lost in
person?
thought. I beg your pardon, Madam Chair. To my right is Madam Joyce Maina. She's the RAMCA coordinator, reproductive, maternal, neonatal, child, and adolescent health coordinator. Madam Nelly Wangari is the county nursing officer, and of course the FP family planning logistician. I think that is the entire complement.
Thank you
of our
very
team.
much, Nyeri team. Most welcome. You come from near here, at least. I think you're a full house. We move to Siaya.
Thank you. Good morning.
Good morning.
Pindi Felix from Siaya County, standing in the office of the director. My background, I'm a pharmacist. With Dr. Buya Kerry, sub-county MOH, one of our sub-county called Bondo. Then we have Mr. Milambo Joel, the county focal person at the county level. We have Quinto Makoha, the sub-county pharmaceutical facilitator for one of our sub-county called Ugenya. Thank you.
Thank you very much, Siaya team. We move to Trans Nzoia, who should be near you. And as you mentioned the names of your colleagues, let them raise their hands so that we know who owns that name. Thank you.
Good morning once again. Mulembe. When I say Mulembe, just say Swa Swa. Mulembe.
Swa Swa.
Mulembe.
Swa Swa.
My name is Masibo Sami. I am proudly a pharmacist and the County Director for Health for Trans Nzoia County, the bread basket of Kenya. Although increasingly we are remaining with the basket, the bread went. I have two colleagues of mine today, Dr. Juma Barasa, who is the county pharmacist, and we also have Angelina Uma, who is the AP logistician for the county. Oh, there's Betty as well, who is the RH coordinator for the county.
Thank you very much. Thank you. Thank you. We move to Wajir, if you are here. Wajir. Wajir. I don't know how to pronounce it, whether it's Wajir or Wajir. Yeah, there you go.
Good morning.
Morning.
I have the pleasure to introduce my team. Here we have Dr. Ahmed, who is a pharmacist.
Dr. Ahmed, good, yes.
Mr. Mohammed, who is representing the director. Sarah Ado, RH coordinator, and myself, Abdul Hussein, County Community Strategy for Kolpasun. Thank you.
Thank you very much. And karibu sana. Turkana, are you here? Turkana. Okay.
Good morning, everyone. My name is Dr. Gilchrist Lokoel. Lokoel, we come from the oil-producing county of Turkana. But we are not sure whether the oil is flowing anymore. With me on my immediate left is Mr. Dalmas Lokok. He's the acting county public health officer. Then we have our county pharmacist, Dr. Brian Moyokani, just right there across. And finally, we have Madam Maureen Tum, our acting county community focal strategy person. I think she must be on her way in. Thank you very much.
Thank you, Turkan. We now move to Mandera. Mandera. Are we here, Mandera?
Good morning. Thank you. My next on the other side of the table is Dr. Abdurrahman Ado, our county pharmacist. Up there is Haret Sugo, who is the county nutrition coordinator. And at the back is Hassan Mohammed Ado, RH coordinator, and Mohammed Arda Hassan, deputy director of public health, also coordinating community health.
So I think I've loud enough. We move to county number 001 to be our last county. And that means that does not mean that you are last because you are number 1. 001. Where are you? Yeah. County 001. Give this one.
Good morning once again. Dr. Mohammed Hanif, county pharmacist. My colleagues have refused to stand up. Please be proud of 001. They're all concentrated on that side. I think that's the coastal region. Kutakuwa na bahari pale somewhere. We have Isaac Jewa, who is our EPI logistician at the county level. Matron Mwanakarama Mohammed, our RH coordinator, and Shali Monyumba, who is our sub-county public health nurse. Thank you.
Thank you all. Thank you very much for the introduction. I am told there are more partners who support us who are not here, but as they come in, we'll be able to recognize them. Now, it's my humble request to ask Dr. Salim to come and give his remarks as we start this meeting. Welcome, Dr. Salim. You can give a hand of applause as he comes over, please. Thank you very much.
Good morning. Asante Amos, Chair. I usually follow instruction very much, and I'm told do this, I do that. I want to break no. Better. Lady CHV told me nimepata bwana. So I did not introduce myself. I want to in a manner that is graphic. The people here are wondering why I'm not in the Wajir's table. My favorite. I lot. At least a good percentage mnaona hapa, si ndio? So I was given 30 minutes. My first 5 minutes nataka kujiintroduce. You can identify yourself with this. So usually I don't label this, but because of time, I've done this labeling. Siu is where I was born. It is a village in Lamu, in Pate. I hope you have heard of Pate Island. That's where I come from. Kisumu, these are my in-laws. That's where I'm married. So I'm married in Kisumu. Moyale was my first posting because at that time, the provincial medical officer thought I was coming from here. So actually told him he's taking me very far from home. But that was my first posting. So Nairobi is the national level where I work and where my immediate family is. So that's my introduction. In terms of function, I'm the head of the Department of Primary Healthcare. Usually, I don't usually say it in English. I usually say it in Kiswahili, but most of the time when I say that, most people get lost. Mimi ndio mkurugenzi wa idara ya utunzi ya afya ya msingi ambayo ina sehemu msingi na iko na sehemu ya kuboresha afya. So those are the three sections. Division of Health Promotion, Division of Community Health, and Division of Primary Health Services and Family Medicine. So I hope tuko pamoja. So one, I want to thank the organizers of this. For me, this is a very important occasion. Before I continue with my small speech, which I had written but not want to read it because of time, I want to give apologies from Dr. Kim Sitine. Sitine is the head of the Directorate of Health Management, Information, Research, and M&E. He would have really liked to be here, but he had another function that he had to attend. But he called me very early in the morning to give me his talking remarks. So I have his talking points. So briefly, one, I think we all know that access to health services is very important, and that's where the government implementing the UHC. Secondly, I think technology is a very important part of the ministry and the government. Directly under health, we have the digital health platform that we are embarking on. And with this platform, it will have about 23 modules, including one of them, the commodity module. And this is all to put all the health information together. The government is also going to have a data warehouse where all health information must be there. So for all the partners that are working on the same, and it is health data, they should be linking with us so that we can actually put it under the same place. Secondly, there's the data management So there's a data management act that is already there by the government. It's very important for any partner, any person dealing with data, IT, technology, to go through the same and know what it entails and what are the conditions in it. Under the ministry directly, we have several documents in terms of ICT policies, standards, that if you're going to work in the space of technology, you need at least to be aware of those documents so that you're not moving away from the same. We are not going to curtail anybody from any tech issues, so long as they are interoperable with our system, they are following the Government Data Act and our ICT documents. The other thing for us directly under primary healthcare, I think currently we are working on the primary healthcare networks where we are trying to link the level 4, level 3, level 2, and level 1 for us to increase access to services, but more importantly, to make bring the synergy that is needed, because we know there's a lot of shortages under human resource. So if this institution, the cadres that in this institution can work together, and especially looking at preventive and promotive health, it will be very important. And we know in this space, the issue of technology is very important, which is one of the areas in supply is competent and working on the same. Without commodities, we need to be a big challenge. There's a lot of stock out, there's a lot of problems in terms of distribution and all that. So I think this system gives us an opportunity on how to manage the same. But under the system, I think more importantly to me is how to bring in people to work together, the synergy and the modules actually to do the same. Many people talk about how can we work together, how do we bring people in terms of coordination and consensus. But actually, when we go through the packages that they have, the learning packages, it actually does that quite well. And I think we hear about the impact teams. I think for us, as we're implementing our community health strategy, we are currently focusing on operationalization of the community health units. And one of the main important components under this is we are having the community health kit. And when the community health kit becomes available to all the counties, we will actually find that already there's something or a system that we can manage the same. I think last thing I want to talk about is sustainability. I think it will be very unfortunate if we start something and then we cannot sustain the same. So hopefully from these discussions and from the people, the counties that have been implementing, they're actually focusing on how they continue, even if in supply moves away or there are no other partners, so that we can actually integrate and mainstream the same.
Asanteni sana, nashukuru, and I was not told to open this officially, but I take that mandate. I've opened the workshop officially. Asanteni sana.
Thank you very much, Dr. Thank you and feel most welcome. We also want to recognize there are our teams in the 9 counties and within Nairobi that are also in this meeting online through Zoom. So let them also feel most welcome to this meeting. Again, thank you very much. And I think my session is now over. Judith, could you come and take it over from here? Thank you very much. Again, our team, we have an in-supply team that we have not introduced, but as they come to make presentations, you'll get to know them. I'm sure they have introduced themselves, but let me also mention our CEO, Dr. Yasmin Chandani, who is leading us here. Feel most welcome, Dr. Thank you.
Thank you so much, Amos, for leading us through that. I don't feel like we gave Dr. Salim a good appreciation. He gave us our opening remarks and a bit of motivation on what they are doing at the community. So perhaps we can take a moment to appreciate him. Kuna clap, there's a clap that, is there a clap that we can, community health people, yes? I'm calling on you. Laura, what's your slogan? One CU at a time. Just like Dr. Salim is getting us to operationalize community units, we want to reach one community unit at a time. So community team, please give us a way to appreciate Dr. Salim. George Okello.
Yes. Yes. So I think this is Dr. Salim, and just to light up the house with some energy, we're going to do type of class. How many of us know?
Yes.
Okay. So there will be songs and we'll be talking. So if I say Carabanda, there are those of us who know will be clapping. Carabanda. Carabanda. Eita. Okay. So that's how it will go. So I'll start. Carabanda. Carabanda. Carabanda.
Thank you so much, George. That's more like it. Let's make it lively. Okay, as Amos Chair mentioned, we have our impact team members, the ones who implement these projects. They are joining us online. All of them could not make it here because we had to also observe COVID protocols. So they are following online and we'll be giving them a chance to also interact with us. So please feel most welcome. And because they are online, we are in the digital age. We have some hashtags. Nani ashasikia hashtag? Hashtaggy. Johnson Stable, do you know what a hashtag is? We want to make this event trend with those slogans that you came up with. And the person who tweets or retweets some of the slogans that have come up, at the end of the day, we'll walk out of here with a prize, with a grand prize, bigger than what the trophies you're seeing behind there. So please tweet, please retweet. Our hashtag is hashtag scale project, hashtag InSupplyDU 2021, hashtag data use. You can use any of those. Tag InSupply, tag at JudyPalm, that's me, tag your friend, let them retweet, and we see who gets out of here with a grand prize. And we get people to know what we are doing behind the scenes in terms of building stronger supply chains with data. I'll make a few announcements and then welcome Yasmin to come in for her presentation. I know most of you have come from the counties. We will be talking to you. Your point persons will be reaching out to you for your logistics. So don't worry. So I will, Transoya people can see me on the side. Yes, and we will get the logistics sorted out. For the small room, as you walk out, you will see a sign on your left that shows you where they are. And I think that's it for the housekeeping and announcement. And it's my pleasure to welcome our CEO, Yasmin Chandani, to just walk us through what InSupply has been doing. Welcome, Yasmin.
Thank you very much. Good morning. Thank you so much. Good morning, everyone. Welcome to everyone who is here in the room. Dr. Salim, thank you for very inspiring welcome remarks. And thank you to everyone who is online with us today. First, I'll say it gives me so much pleasure to see everyone here in person. I know it's been a difficult few years with a lot that we've had to do virtually. And I know that we've become so much stronger at figuring out how to stay connected, how to keep our programs moving, how to still see results, even as we have to engage virtually. But today, it's reminded me how important it is for us to connect in person. And thank you everyone for taking the time to spend time with us today, to hear from each other and to learn from each other. So today, as you've seen with the agenda, and as Judy mentioned, we are trying to make this very little about in-supply and a lot about the counties and the national program. Most of today you will hear from each of you in the room, because that's who's been doing the work. The work has been really done by the counties and the national program, and they are the ones who have lessons, who have stories to share. And you will hear from me today a little bit about how In-Supply approaches the work. So I'll talk a little bit about our human-centered approach. I hope you enjoyed it. You had a small taste of it when you went to the room with our problem and solution tables. What we try and do is we try and listen to all of you and to everyone who is in the health system, and use that as the starting point. So for today, I'll go very quickly through a brief presentation I have that is really a summary of several years' work, just in a few minutes. And then we can hear from all the colleagues in the room. So a little bit about who In-Supply is. We're a very new organization. We are an East African organization. We're headquartered in Nairobi. We have an office in Tanzania. And every single one of us on the team is from the countries we're in. So I'm Kenyan. The whole team here is Kenyan. The Tanzania team is led by a Tanzania. And that is deliberate. That is part of who we are. We believe in locally led, contextualized solutions. And we believe there is so much value in learning from the bigger world around us, but that the people who best understand how to customize the solution are people who are closest to the context. We're affiliated with JSI. I think some of you may have heard of JSI, John Snow Inc. In-Supply is only 2 years old. So often we started as JSI as we were transitioning. And so sometimes you may be a bit confused. We're still one family. We work together very closely. Some of the ways in which we work is a little bit different. And so I just wanted to clear up that confusion. One of the things I'm sharing our mission and our vision because we're new, and also because to share exactly what we do that is different. So we co-create, and we're very committed to both innovation and sustainability. That's not two words you often hear together, but for us, those two go hand in hand. Innovation is how we keep moving forward, but sustainability has to be part of it. As Dr. Salim said, we can't start something without thinking about how it's going to keep going after we go. So some of the things that In-Supply does differently, as I mentioned, we are able to benefit from the JSI relationship, and we have that global perspective. We draw on our colleagues from JSI when we may not have the expertise. We also learn from them. We learn from the bigger community, but ultimately it comes down to contextualizing everything. So we localize and we co-create with our partners on the ground. And you'll hear that as we go through some of the projects. Every single one of them was actually co-created with the impact teams and the communities we work with. And so the solutions are not really ours, they're theirs. And that's why you're going to hear from them today. We also believe in supply chains in particular, the process is super important. For many years, supply chains have focused on one output, stock out rates. And that's a really important output because that decides whether or not people are able to, as I was talking to my colleague from Transoya and even from SIAYA, if community health volunteers don't have products, they lose trust of the community. We've invested in service delivery. We've invested in so many things. And when the commodity falls short, then all that investment is lost. But the problem with building a strong supply chain, you can't focus only on one outcome. You have to understand the whole system and invest in the whole system. So we believe a lot in investing in processes and the system. And finally, our signature approach is to really put people, process, and data at the center of our solutions. We are secretly inside, we're a bunch of data nerds. We love data. We really look at data to help us answer the problems. But we also use data to not only quantitative data, but we use data from our users. We listen to them, we hear their voices, because fundamentally, supply chains are implemented by people. And ensuring that those people have the right capacity and are motivated is more important than anything else. So we bring all these things together. This is a little bit about some of the clients and partners we've worked with. We've been very privileged to be a partner with the government in Kenya at the national and the county levels, and for many years. So you will see the 9 counties in this room, and we value and treasure that relationship. We've also worked with a total of 17 in Kenya. And so we believe very much that change will happen at the subnational level, and that they're the ones who are going to lead us into the future. So this is the current footprint we have in Kenya. All of you, hopefully we colored in your counties, right? And you can recognize them on this map. And the projects that we'll hear about today, we've had the privilege of partnering with 9 counties. We work with 43 impact teams, which are cover 53 sub-counties. So not every sub-county has its own impact team. In some places, especially for example, Nairobi, in Mombasa, some of the sub-counties come together and have a joint impact team. And we have worked with 281 community health assistants and over 3,500 CHVs, community health volunteers. They are our frontline workers, and they're the ones who we really miss today, but who are represented here in the work they do and in their spirit. So the first project I'll talk about very briefly is called Data Use. And that's where the impact teams have really grown and evolved. The slide is very, very busy, and that was done deliberately because data use has many components to it. There is, for those of you who have been through the data use and impact team approach, you'll recognize our blue signature circle. It's the innovate, do, review cycle that impact teams are based on, the traditional quality improvement approach that has evolved with input from all the counties that we work with. Just next to the blue circle, you'll see a little dashboard. Many of you saw it at the solution table outside. That is the ITT, the indicator tracking tool. And that is your own data that we present back in the form of a Power BI dashboard. So that's KHIS data that listening to the voices of the counties, they have said, this is what will help us make our decisions. This is what will help us use our data. And that ITT is the same data that everyone has access to, but presented in a way that lends itself to supply chain decision-making. Below that, you see, we might rename some of these personalities, but this is part of our human-centered design approach. This evolved from the first iteration of impact teams, where we realized that there was a capacity gap, but that the capacity gap was not one that we wanted to fill with traditional classroom training. That's where we developed a user-focused, self-paced capacity building approach. You can use a phone. You can decide which persona you are and basically learn that skill on your own time. And you'll hear during the recognition section later, you'll hear many people in this room who have mastered skills and achieved competency. We have 7 personas, 4 of which are core personas, 3 of which are enabling. So I was having a discussion this morning. One of our key personas is called Organizing Otto, as many of you know. And they were like, why didn't you call him Onyango? Right? That would have been more local. And we wanted to acknowledge that maybe Onyango is not a relevant name in Tanzania, but maybe we can use some Swahili like Omari so I think we might go through a rebrand with some of these personas and make them our personas. And then lastly, you'll see this, last but not least, you'll see the last dashboard in the corner. And this was work we did around trying to improve data use for cold chain equipment, remote temperature monitoring. Mr. Some has been such a great partner of ours on this. And this is like one of those forgotten children, right? The cold chain remote temperature monitoring keeps our vaccines cold. We know how important that became during COVID. And so the focus here was using human-centered design to basically understand, how do we make that data usable? How do we make it easy for technicians to understand what's going wrong and to take action? And the same with the EPI logisticians. And again, you'll hear about that later. A very quick overview of how the impact team approach has evolved. I just want to again underline, it started out in 2016 and 2018. Dr. Hanif was one of our first implementers of the impact team approach in Mombasa. And it was very much focused at the county level. And through iterations and through listening to him and others who implemented it, we evolved the approach. It now works at the sub-county level. That's the operational level. That's the level that works really well to problem solve, troubleshoot, take action. And we've seen really amazing results with some of these impact teams. If you look at the family planning data, the immunization data, we've got increased reporting rates compared to non-impact team sites. We've got better inventory management, fewer stockouts. So this approach works, and it works because the counties themselves have given us the feedback and shown us what's the best way to make it sustainable, what's the best way to embed this, and what's the best way the data can work when it serves their purpose. Scale is the second project that you'll hear about today. And again, you'll see human-centered design come up. When we first started, Siaya was one of our first counties with C-Stock. And we implemented as a pilot in Bondo and Ugunja. And after that, it became very clear that this was a solution that could work, that could inspire confidence for community health volunteers to manage commodities. But it needed to be adapted to all parts of Kenya. Dr. Salim was one of the first leaders we spoke to, and he actually launched the idea of C-Stock in Kenya. And he said to us, you know, C-Stock has got to work everywhere. It can't just work in those counties that have resources, that have connectivity. It's got to work, and it's got to unify the whole country. So we took up that challenge, and we used human-centered design and started working in some of the hard-to-reach areas where we have nomadic communities. We may have different education and literacy levels. And we made sure that C-Stock could be used by every CHV in the country, not just those ones that have Android phones. And so that's another success story you'll hear about today, and we're really excited about that. The other work, so in scale, you'll see C-Stock, which is a source of data at the end of the supply chain. You'll see impact teams again. They were adjusted for these different settings. And the other thing you'll hear about is an approach we used called development evaluation. It's a utilization-focused M&E approach. And basically what that means is we don't wait until the end of the project to measure impact and see how we did. We try and do that continuously. And it's a very participatory approach. It's not for us to tell you this is how we're doing. It's for us to come together and say, what is the data saying to us? Let's all make sense of it. And all of you have participated in our DE approach. And that has been something that we're very proud of, is being leaders in how evaluation needs to change in complex settings and with complicated systems that are dynamic. So here are some of the scale milestones. We started in November 2018. Obviously, when COVID came, it was literally the week we were supposed to start C-Stock rollout. So we had a little bit of a bump, but we actually, together with our partners and our county partners, we took a virtual approach to begin with, and then we transitioned to physical. And since then, once the rollout was complete, we've really focused on institutionalization, continuous monitoring, and understanding how do we strengthen that system. And that's where the DE came in. We'd hear from the CHVs, we'd hear from the sub-counties, and adjust our approach to make it work. So just as I've mentioned, we've tried to partner with the ministry, the national, the county, the sub-county governments at all stages. In design and co-creation, the impact teams, we deliberately formed human-centered design teams and went out and heard from everyone. How can we improve impact team design? How can we, with development evaluation, we've had sense-making meetings at national and at county levels that bring in the perspectives and that help us interpret the data in a way that can be usable. And then with our TOTs, we've established national teams, TOT teams, county TOT teams, sub-county, and even SHA TOTs, so that when we go, there's no capacity gap. The system can continue to roll out. There are champions within the ministry, and all of this does not depend on in-supply. And finally, we looked at how do we break down sustainability. Integration is a really important component. And as Dr. Salim said, one of the milestones we're very proud about is integrating C-Stock within KHIS under the leadership of the ministry at different levels. And of course, integrating impact teams into the different fora at the county and sub-county levels. I'll just take 2 slides, very high-level outputs of what we found. So we used an approach called outcome harvesting. Again, it might sound new. The concept is similar to DE. It is an approach that works really well in complex settings and when there's a lot of change. So not only in the ASAL counties, which are very complicated to work in because they experience so many natural disasters, climate change, so many things, but also COVID. COVID has affected all of us. If we tried to use traditional evaluation approaches at the start, probably it wouldn't be very helpful for us in terms of lessons learned and moving forward. So outcome harvesting looks at unintended and intended outcomes. And what we do is we use a very participatory approach. So we pulled together many of you or your colleagues as substantiators, and they sat down with the outcomes and they decided, do these make sense? Do we agree with them? How might we change them? And the finding was that most substantiators fully agreed with the outcomes. None of them disagreed. They gave really valuable input. So the original outcomes changed through their participation. And so we harvested 19 total outcomes across scale and data use. Some of the examples are here. For example, impact teams provide a structured, resilient, and flexible way to review data to inform decision-making. And this came from across the counties, all the 9 counties. And if you know Kenya, which of course all of us do, many of these 9 counties are in very different circumstances, but all of them found ways to make impact teams work and make decision-making better. The second finding or outcome that we want to highlight is that CSTOC is an effective way to bring services to underserved populations. And that was our goal. So we felt very good about that goal. You can see there's other outcomes. These 19 are spread out and we categorize them. So several approaches for sustainability and ownership emerged around the IT approach. One of the other outcomes was a standardized community health commodity reporting tool. And as I said, integration of CSTOC data and KHIS. That means every KHIS user who has a login can access that data. It is not dependent on in-supply. Improved commodity management practices. One of the things I feel really great about is that when we first started, there was a lot of hesitation about whether community health volunteers could be trusted to manage commodities. Right? They're volunteers, many, especially in different areas, may not have high literacy. How could we trust our valuable commodities with them? Because of CSTOC and because the community health volunteers themselves use CSTOC and understand it, there has been a change in county leadership deciding, you know what, we see the data, we can trust them, we're going to start buying commodities. And if we want to achieve UHC goals, that's such an important goal for us, to make sure that we can equip CHVs with the right tools they need to be successful. And then finally, as I mentioned, improved data visibility. We all heard the beautiful data slogans today. We know how important data is for supply chains, and both the ITT and CSTOC improve data visibility across different commodity categories. So with that, I'm going to hand it back to Judy just to say that, again, today we're going to have 4 panels, and the panels will directly share their achievements, their lessons, their challenges, and their plans for sustainability. So we deliberately designed the panel so that you can hear the voices of the county, and the counties will not present everything they've done. As Judy said, they're going to take 5 minutes. They're going to focus on one area that they wanted to showcase. For example, one county might focus on impact teams, another on CSTOC, another on DE. They will share the snapshot of what they have learned over the years, and you will hear from them and have the chance to ask them questions about how it's gone. And then once we have these 2 data spotlight projects, we'll move into 2 panels on sustainability. And that will be a seated panel with members of the county where we can all hear from them on their plans for sustainability and also ask questions so that we can learn from each other. The goal for today is to learn from each other so that we can help improve ourselves, but also scale up what works. So thank you very much, and really excited to have a great day today. Back to you, Judy.
Thank you so much, Yasmin. You've heard from our CEO the perspective from where we sit from in supply, what we feel our achievements are. 19 outcomes. Yeah, that's what we collected. And when we substantiated it with our partners, our implementers, they agreed with them. and we want to hear from them. So George will take us through the first project, which is SCALE. He will tell us what SCALE is, and he will welcome the counties that have been implementing this project to just give us a 5-minute snapshot of what they have implemented and what their achievements are. And then I would just like to mention something. There are some sticky notes on your table. This one's over here. Yeah? Please feel free to use them and write something that stands out from those presentations. At the end of the presentations, we will collect them and put them on each flip chart. If it's a gap, if it's an opportunity, if it's something that brings out another idea, just write it down. We will collect it and put it around.
Thank you, Judy.
So we're going to have this opportunity to hear from our teams, the MOH counterparts from the ground. And just very quickly, before even we move, I want to introduce the project that we've all heard about, the acronym SCALE. So SCALE is a project that is implemented in 4 of the hard-to-reach counties in Kenya. That is Wajir, Mandera, Turkana, and Samburu. And SCALE stands for Supply Chain Alternatives for Last Mile Equity. And all that builds into the UHC agenda that we talk about. And what we've seen with SCALE is that it focuses on different implementation aspects. And we're going to have this opportunity for us to see what has been happening on the counties. So the first opportunity I'm going to give to Siaya in retro for us to look at where CSTOC started, because the anchor project or the anchor implementation approach in SCALE projects was CSTOC. So I want to give this opportunity to the Siaya team to just come and share with us their journey for CSTOC. So Dr. Kari, please. Thank you. So let's be ready with our sticky notes. We'll have an opportunity just as he'll be presenting. And then the timekeeper, he has 5 minutes. So
good morning, everyone. This is Siaya County's presentation on CSTOC implementation from the period it started till October 2021. So in Siaya County, you have 2,128 CHVs and 221 community health units that are implementing community health services, and they are fully functional. But out of that, we have some CHVs and community units, as indicated there, that are supported by partners to be able to effectively do their services at the end of the day. But in part of their work, there is a use of manual reporting tools. And as many of you have worked in service, you have the longitudinal registers, which are very cumbersome to carry, and they also to use back at the community. So at the end of the day, there was the linkage between CHV's reporting and community units' monthly commodity reports was a challenge that we could not effectively point out how best these people are working. And this non-visibility and performance on commodity use was limited up to a certain level. Thus, while trying to track the stockouts and commodity availability at the individual CHV level was something that was not possible at all times unless you go for a support supervision, and that was dependent only to the partner-supported areas. At the intermediate level, that is the community health assistant, they had also inadequate data visualization skills and use of data in commodity management. So through CSTOC, which was pegged on various areas, use of mobile technology, which generated to user-friendly dashboards, and the impact team to support the process, we were able to do and train both the CHVs, the CHARs, the sub-county health management, the county health management, and also part of the executive on the process of how we can use mobile technology to collect data, which will be used through a user-friendly and generate a user-friendly dashboard. And through meetings for impact teams on a monthly basis, you could generate information from the dashboards to make decisions on what best can be done to supply this information. So in terms of results, CSTOC has several components, as has been done. So the focus mainly is on the receipts of medicines and reporting of stock on hand and dispensed at the end of the day. So this is Sierra County's performance at the start of the project in November 2020 till October 2021 for last month. In terms of receipts, one of the challenges, as I pointed out in the problem statement, was that we were unable to see as a county at individual CHV level what each CHV is able to receive. So at the start of the project, the receipts was as low as 32%, and I said we were at 2,138, and we could only effectively see 620. So we had an incremental reporting from 32 to 53. And stock on hand and dispense was improved from 41 to 79. The disparity between the two, despite being one CHV, is pointed out that when the stock on hand and dispense is being reported, they have physical meetings in which they actually report what they have at the time they are doing the report. But the receipts is only done once the reports, they receive commodities from the facilities. So that is why there's a slight difference between the two. We have 6 sub-counties in Siaya, Elegu, Songa, Bondo, where I work, Game, Gunja, and my colleague Ugenya is also represented here, and Rarieda. So we have as low as 27%, but there's an incremental up to 81 for the reporting month. We have 55 who are there to Gunja. We also have Bondo, which was the highest from 39 up to 93 or 88 from the graph. But what it just points out is that we are able to see effectively that if there's a forum, if there's a platform for people to report and see where the commodities are, because one challenge that was always there, a particular community unit will not offer community health services because you don't know whether they have those commodities or not. But if you're able to see what they have in terms of stock on hand, and if they have dispensed, means that a service was offered, a life was saved at the end of the day. So the receipts offer a very different perspective, just to show whether the intermediate supervisor at the facility are offering these commodities to the community health units. And you also have the various sub-counties. And the big spike in April shows the supply of commodities from maybe KEMSA, because also KEMSA supplies on different dates. And this availability also goes down as commodities also get stocked out from the facilities. So the receipts just shows that at some point in time, there is maximum availability and maximum supply to the community health units. And some point, there are some sub-counties in which you can effectively monitor at the county level and be able to know which sub-county is able to offer these commodities to the community, which sub-county is not offering these commodities, and what are the reasons, and what are the impact teams doing about it so that commodities can reach the community health units. So these are just some of the community impact teams, which I won't go so much into because there's a portion for that. But it just shows the confidence and also the commitment that the community health units had on every day on the 28th of every month, that they'll be able to do that. I think I was avoiding that side so that it does not show me that time is up. But thank you for that. I'm nearly done. So this is a very important slide because it's just explaining what worked well and what are the challenges that were showing up. The use of TOTs from the top level up to the bottom level, that at the CHV level, was able to cascade the information. We saw more of the CHVs reporting so that we could be able to see who has what. The sub-county WhatsApp groups worked very well to show about troubleshooting The community impact teams, as compared to the sub-county impact teams, worked well. In contrast to the sub-county impact teams, did not work so well, but as compared to the community impact teams, but there was an improvement in terms of meeting the objectives. The child learning sessions, incorporating CSTOC as a performance indicator, use of the hard copy tools in collaboration with the CSTOC application made things easier as a comparison. What I talked about, low reporting of stock on hand and dispensed. Follow-up on non-active community units was a challenge, as I mentioned in the problem statement. There are some that are supported, some are not supported. So for this to go on, we need all community units to work out. This is mainly to the national program. There were several partners who have different, which was brought up when the team from the national visited us in Bondo. The issue of having several mobile applications, you can forget passwords at the end of the day. So the lesson learned, just as I finish up, is that visibility enhances accountability, resupply, and stock status of commodities. And then the inactive community health units as CHVs can be visible in terms of knowing which one is performing better, which one are doing better. And I can quote one of the CUs in our sub-county. One CHV felt that she's glad and happy that CSTOC brought the national program up to her level. I remember Dr. Salim was in that meeting, and she was very happy that her good work actually brought people to come and appreciate her. So invest in mobile technology and at all levels it makes data visibility possible at all levels. And involvement of all stakeholders from the CHV to the counter leadership facilitates the process. And child learning sessions are always a good learning forum for continuous updates. And as part of the sustainability, an enabling environment is also key in doing CSTOC, because without the political goodwill, without the leadership, without the funds, without the planning that is needed to do these sessions and also these aspects, we will not be able to succeed in CSTOC. Thank you so much.
Thank you so much, Dr. Kari, for your presentation. And before I welcome the next presenter, I want to negotiate for 5 minutes of your time from your 20 minutes of tea. If I'm allowed, we could later on break for tea for 15 minutes. So I see all of us nodding, so thank you very much. Ashia Oleng to Dr. Kari, and that is the cue for Dr. Mungai to come in and share with us the Samburu presentation on developmental evaluation. Karibu sana, Daktari.
Thank you, George. Good morning. Yes, my name is Mungai, as George has stated, and I'll be presenting for Samburu County. As you're all aware, Samburu is a huge county, around almost 22,000 square kilometers. To put that into perspective, Nairobi is 691 square kilometers. So it's a vast county, nomadic cultures. And we had numerous challenges with access to visibility of commodities at the community level. I can see there's a picture there. That's one corner of Samburu. So the problem statement that we actually identified was there is poor linkage between the health facility and the community. And the community health services was aimed at improving the health outcomes of the community by having early community-based healthcare interventions through CHV, so as to treat various minor health conditions at their onset and reduce the need for referrals for conditions which could have been easily identified and treated at the community level. And we've actually realized that within the county, the referral system is a challenge due to geographical access, geographical isolation, the distances between the community and the link health facility. And in some instances, the distances between each health facility could be an average 50 kilometers. So you can imagine if the CHV can intervene at the initial stages. That will greatly reduce our costs instead of dealing with emergencies. So that was one issue we had seen. The second was CHVs, being volunteers, have a lot of duties they perform in their communities, and they end up using the time they would have used to do their personal family duties to serve the community. Okay, they need motivation from their families, communities, and county governments to improve their zeal to work. So you find that currently the CHVs we have in Samburu, there is no stipend. So you can imagine someone going out of their way to reach different households. Maybe one CHV has 50 households, and these households they are nomadic. Today they're here, tomorrow they have shifted. So, and we realized that part of this was identifying CHVs who have the heart and the will and the passion to go and do this job without any stipend coming through. But of course, there are some measures we have taken as a county to address that motivation. And the third problem statement was CHVs were not issued with commodities because there was a lack of accountability for commodities, plus required commodities were not budgeted for by the county government. So that one we personally took as an initiative when we were doing our procurement for the HPTs. We factored in basic commodities, which we could actually issue to the link facility, and through the C-stock, we could actually have, it was the answer for our visibility at the community level. And it has greatly helped. And for us to actually make it, operationalize it, we had to do some letters from my office to each of the sub-counties, detailing that it's okay to give these commodities. And we identified the basic commodities which we could supply through the link facility, the CHVs. And through C-stock, now we have that, created that accountability aspect to know what is moving, what is being consumed, and the mobility patterns. And we actually, the data was actually informing us on what to actually stock going forward. So we had the developmental evaluation, and there were, as you can see, there were 3 waves: wave 1, wave 2, and wave 3. And for the community health strategy, which was wave 1, we are actually now looking at the CHV recruitment, because we need someone who is willing to actually go out of their way to travel on average maybe 20 kilometers per day on foot to address, to reach out to the communities, the households, interact with the households, see what the challenges are, come back with information to the link, the health in charge, the link facility. And you can imagine that journey. It's not easy. Samburu is, of course, there are some hostile areas, there are wild animals in between. There is no the water, there is no geographical access, rough terrain. But now we had to identify CHVs who have the passion to do this job. Then also, we also had to talk to the CHVs to also give them guidelines on how to approach the challenges that they were having as they go towards these communities, which are, as I said, they're really dispersed. Yeah. And then also looking at the modalities of what commodities do we give, because we have to take into account the literacy levels of the CHVs. There are some who are literate, some who are not literate at all. So it actually determined what commodities can we give, what quantities can we give. We had to actually limit some of the quantities. And I have 2 minutes. Thank you. So for Samburu, this program was very important and really helped us with our access. So now the 2-minute thing has confused me. But anyway, now wave 2, as you can see, I think you can see the area of focus there was creating sustainability and community-based distribution. And also COVID came, we had to actually issue masks and also train the CHVs on what to do, provide them with sanitizers, just to make sure that at least they're comfortable interacting with the various households. Then the wave 3 now was understanding the barriers which were hindering or which would have affected our community-based approach and how to mitigate them. And then the importance of the CHARs, dealing with the CHVs. And also what was key was now the communication. Without communication, bottom up, top down, at least it helped us go forward, especially the bottom up. Yeah, so I think I'll go to the results. As you can see, the DE, Of course, we identified those CHVs who have that passion. Of course, we tried our best and we did our best through the impact teams to make sure there was an uninterrupted supply of commodities where we could intervene. Some of the commodities were out of our control. Of course, we do procure from, and I won't go into that one for now. Now, in fact, even I had issues. I called the camps, I told them I need drugs. They told me, go and talk to the military. So we are yet to cross that bridge, but we'll see the way forward. Then, of course, recognizing the positive impact the CHVs have had. And we have actually seen and we empowered, we have actually rewarded, recognized them. I think we've even issued some certificates, some awards to some of these CHVs who have actually done and gone out of their way. And this has actually had a ripple effect towards the other CHVs. It actually gives them that energy and that impetus to go the extra mile. And then also the wave 3, increased uptake of professional services. We realized there's improved outcomes as a result of this, and the communities are more curious to know what's going on and actually seek professional health services. Considering Samburu we have a lot of traditional medicine, traditional healers. So what has worked well? I'm still within the 2 minutes. Each wave of activity was disseminated to the county team. Also, the CHMT was involved and the executive was informed of the progress that we're making. And actually, you could see from the data that there was actually improved outcomes going forward. But what I would say is the key thing here was the communication and also dissemination of our activities, the impact teams. We meet at the sub-county level, they meet monthly. At the county level, we actually call each of the sub-counties and we have our county commodity security technical working group meetings, which we hold quarterly. And in those meetings, we actually interrogate, we challenge. And I think I was in that room where we were going around the different stations. And I think one of Ken showed me some data. And they're telling me some of the data here, there are 4 facilities which did not report. And I could confidently tell him, I know, because these 2 facilities, 1 had an accident, 3 went on maternity leave. And actually, because of the impact teams, I could drill down to each facility and had visibility of what is going on in those facilities because of this program. So, in short, I have answers to all our problems, but not the solutions yet. That one is work in progress. So, one of the challenges we were having is competing activities in the county. You want to call these particular officers, but other partners have pulled them. Then, Samburu is vast. You have to plan ahead. And if you pull out some people from particular facilities, it's an issue because they won't give service. Yes, so the lessons learned, I think now, I'm okay. Just the one slide and there's no other. So lessons learned, training of CHVs is inconsistent and mostly partner driven, which we want to change. And lack of financial compensation for CHVs reduce their motivation to work. I'll be happy to mention that Samburu County, we actually have a CHS bill, which has been passed by MCAs. We had to pull them out of Samburu somewhere, talk to them, I think in Nakuru, and house them and everything, and they agreed and they passed it. And I think 2 weeks ago, a bill was done at the county assembly, which has now put aside 50 million for CHS activities. And I think beginning end of December, each CHV now will be getting, I think, around 2,000 shillings. So that's a big step. And you can clap for us. I said, to Mejaribu. So that is now, I think, as Yasmin has been drumming to us, sustainability. Yeah. So that's one of the measures that we have taken to sustain this kind of engagement. Then again, huge distances between households discourages some of the CHVs from accessing all homes. And of course, the poor health-seeking behavior and reliance on traditional healers, which I mentioned, was a challenge as well, changing that mindset. But it's work in progress. It is possible, and we have done it, and we're still doing it. And so the last one, C-stock rollout was not done to all community units. Hence, the morale for CHVs was reduced. Because some of the CHVs who actually, where the C-stock was active, you could see they are more engaged and they're moving and they're excited. But now some of the CHVs who in other units where it's not done, they were asking why is it there and why it should be in my unit as well. So that was a positive for us because we realized, okay, we actually need to scale this up. And I think we will engage with the director and the executive to see how we can now roll it out. And I think one partner, maybe I'd like to mention, one of our partners is interested in actually taking up, because right now CSTOC is only in 2 sub-counties. We have 3 sub-counties in Samburu. It's only in 2. So we want to take it to Samburu North, where Baragoi area. So we want to see how they can engage and plug in and actually take it up, and we continue. So we won't stop going forward. And this will actually help Samburu County because of our unique challenges. And I think I'll stop there. So thank you very much. Yes.
Thank you, Dr. Mungai. Let me see your colored stickies, please. Oh, we've not been writing. So just a quick reminder that we need to identify and document the gaps and opportunities that we see. And as Dr. Mungai has mentioned, there is an opportunity for a new partner to scale CSTOC to the next sub-county from the 2. So as we make these presentations, please interrogate, move along with him or she, so that we can look at some of the opportunities that we have as in supply and as county governments and partners, so that we can move the agenda of UHC through CHVs ahead. So the next presenter is going to be Turkana, and they are going to share with us an innovation that is really changing the way CHVs work. As it comes to the podium, I just want us to reflect. The 2 presentations have really shared with us. The first one, I caught my attention. CHV's reporting rate is at 76% in Siaya. What is the reporting rate for malaria commodities at our county? Then we can compare. We consider CHVs to be low literate. They have difficulties in reporting, but their reporting rate is at 76. What is our reporting rate as healthcare workers? And then Dr. Mungai mentioned they passed a bill, 50 million. The DE Wave 2 actually talked about motivation to CHVs. So as we move along, let us try and see some of the opportunities that we are talking about in our presentation. So I'll give this opportunity to Dalmas. Thank you very much.
Thank you so much, George. Good morning. I'm Dalmas Lokok from Turkana, from a sub-county called Loima. Maybe to say something about the picture. That's a CHV from one of the units who is filling up the PMR. And she's coming from a village like 30 kilometers from the link facility. So my colleague from Samburu was talking about the vastness. Turkana is one of the largest county in Kenya. Yeah, welcome. Yeah, just to kick off, a problem statement, the engagement of community health CHVs to support the delivery of health programs in an established approach that has improved access to primary health care and health outcomes, and other sub areas that is particularly where are health inequalities due to scarcity of the trained human resources. We are just like Samburu, the area is vast, the distance, and even the health workforce is very minimal. So Turkana has been implementing CSTOC in 3 sub-counties. We have Kibish, that is near Ethiopia. We have South, bordering West Pokot, and then we have Loima, bordering Uganda. So we have 7 sub-counties, but where we are implementing is only 3 sub-counties. So we can see a gap there. Challenges still existed, and CHVs had difficulties in reporting, among a number of obstacles in executing their work, including challenges in managing health commodities, low literacy level, inadequate reporting tools. That's what we are facing even right now. Low capability to complete reports because of the literacy level, an existence of avenue for submitting community reports affecting product availability, inadequate access to health, services, especially in arid and semi-arid areas. That's where we are as Turkana County. We are in arid and semi-arid areas, whereby we don't have even public transport, where SHV walks for like 40 kilometers to go to the link health facilities. That's where we are. There is a map for Turkana County. As I said, we have 7 sub-counties. Where stock is happening is in Turkana South, near Turkana West. That is the border to West Pokot. And then Loima is bordering Uganda, as you can see in yellow. And then on the red, where the Turkana North is, Kibish is up there. So Kibish is a sub-county that is not captured in this map. Yeah, piloting in Loima, where we have a yellow, here Loima, that's where the piloting of the C-stock PEPAR happened. And in Loima, we have 34 community health units linked to 34 facilities. But here we are piloting 17 link facilities. That is 17 community health units. And how we implemented stepwise. Step 1, the PEPAR worked with the C-stock on smartphone. That's between August to December 2020. Step 2, stock PEPAR. Then that's when we merged PEPAR and the C-stock. We did the usability testing with the CHVs from 3 CUs, that is Nasigar, Namayana, and Lorengipi. That is within Loima. And and we used the smartphones during that time of the usability testing. Step 3, when we were designing the PEPAR, we had the KIAS, that's a smartphone, like a Mwizi kind of phone that we used to redesign the PEPAR. That was between March and May. Step 4, the feature phones, usability testing. Sorry. With the 30 CHVs and 3 CUs, the CUs that I've said, we were using we were using the feature phones to pilot the PEPAR. Sorry, I'll be very fast because I've seen the time is not on our side. And then we did the rollout. We give all the CHVs, the 200 CHVs in Loima, the feature phones for them to use in terms of reporting through the C-stock. And the 17 CUs with the support from the 17 charts. That was July and August. Monitoring, that is what is like ongoing now. We're doing monitoring, measuring, and performance of the results. It is ongoing now because August and September, we can see it from the data. How it works, briefly, a CHV should log in to a browser, and then the CHV has credentials, and then it will take a photo of that paper. That is hybrid paper that is digitalized, so that it will capture the report, and the report will be captured, and then it will be uploaded to the cloud. And the data comes in terms of the figures. So you can see it is even linked to the KSIS of our systems. So you can see even if you can even access your KSIS, you can see the commodity data that has been uploaded from using this kind of system. The overview of that is hybrid paper into the digital implementation success. What happened to the charts? That is the community health assistance. Sorry. As more control over data quality through community health assistance dashboard. We have that dashboard is able to manage the community health volunteers for the CU by editing details. They can add and they can disable the CHVs. Is able to delegate report on behalf of illiterate CHV or those without a phone. Is able to validate data sent by CHV, or if incorrect, send it back to the CHV to make corrections. The chair is able to monitor CHV's reporting numbers and remind CHVs to submit reports. The chair is able to view stock status for each CHV, which guides in supply of commodities. For a CHV, the CHVs are able to identify which commodity they are dispensing through pictures or icons on the inventory of the inventory cards and stock cards app. the CHVs are able to manage the commodities issued to them by reporting quantity of commodities dispensed, received, and stock at hand or at the end of the month. The results. So we've trained 200 CHVs who are given the feature phones in 17 units, as I said. 200 CHVs have smartphones, a courtesy of Supply Health and Telecom. That is a plus to us. CHVs are able to document the number of commodities they receive, which when compared to monthly consumption, guides the facility in charges, the forecasting and quantification of commodities required at the community level. You can see how the link with the community and the facility are. CHVs manage a number of commodities, started with 17, which are trained. Loima will only have 17 units that are managing the commodities. Monthly data discussions, we have a WhatsApp where we have a platform that we do discussion with sorry, I'm not using the microphones. Yeah, we have a platform for WhatsApp where we do interact with the partners in Supply Health, other partners like Save the Children, in terms of reporting on the C-stock. Stockouts are detected by the system. For instances, where CHV receives 0 commodities, yet they order to be resupplied with the particular commodities. It's possible to know the consumption quantity of each commodity issued to CHV monthly. Coordination with partners, as I said, mostly SAVE and in Supply Health, that the ones who are supporting us to monitor this activity. Just with a snapshot, that is the overview of stock implementation through Turkana. So that's the data from reporting rates from May to October 2021. You can see from Kibish, Loima, and Turkana South. This is a report coming from the CHV. So you can see. The experience sharing, what has worked well, CHVs who are already trained on C-stock before made it easy to roll out the hybrid paper in digital. So they can easily do that. Sorry. The community assistants were unknowledgeable on the reporting on C-stock plus testing. That is what's happening in Asger, Namayana, and Lorengipi, as I said, for the rollout of the paper EMR. The technical team, who is Kenny, George, are quick to support when challenge arises, especially using the WhatsApp. So we appreciate you guys. As HV have phones, cutters of Supply Health, with Telecom also. So we're really proud of you guys, and we need your support to continue. Challenges, we have network challenges. It's difficult for some places where we have challenges with network to do the reporting. So it's a big challenge in our county. Then we had 4 CHVs who lost their phones, but with the support of the community health assistant, they still report. Lesson learned, the reporting using phones in Turkana has enabled team to have data for decision making through the impact teams. And in Turkana, the Mulkamwis that we are using, it is very key for reporting. So Sidara Mulkamwizi. Visibility of CHV data is clear. Now it's clear which unit and which CHV have which commodities. So we are able to monitor commodities. Thank you so much.
Thank you so much, Dalmas. And I'll quickly move on to the next steps. But before I do that, our problem master has all these that we're talking about. So whatever Dalmas has showed us on the slides, there is a demonstration table that if you want to see how C-stock works, how the HP2D works, please join us during the breaks. We can have some 5-10 minutes. As you take your tea, we can show you how these systems all work. So we'll quickly move to a session where we're going to get answers from you regarding the processes and what has been happening. So please take out your phones and go to www.menti.com. This will take a few minutes. And we are going to look at Spotlight, which is on Scale Project. So are we all in? So the code for the Menti is 61838458. The code is 61838458. And we're also requesting participation of those of us who are online. Please log in, go to www.menti.com and use the code 61838458. I'm only seeing 3 participants. Sorry? So how do I tap it? No, they will tap it on the side. Okay. I'm receiving a lot of love. Please tap the love heart once you've joined. We are sending our shout out to those of us who are joining us live on Zoom. Thank you. Any challenges joining Menti? For those of us in the room? One more, then we start. Who is going to be the person who takes us to the next level? That one person. We are 34. I'm waiting for one more person to join. Good, thank you. I wish I had known that person would have given them some chocolates. Who was that one person who joined? Thank you, Mohammed. Please, let's give him some chocolates for pushing us to the next level. So the questions that we would like answers, the team to provide us with answers. One, what was the most interesting thing you picked from the session? Thank you. Please, let's respond. What was the most interesting thing that you picked from the session? Yes. It doesn't have to be just one. You can pick 10 memorable things, right? You like ugali, you like rice, you like chapati, sindio? It's the same thing. Yeah, you spotted Pepper Yemar, you're able to see DE. So we're requesting you to go in there, get your answers. What was the most interesting thing you picked from the session? Great. Impactful. I like that. Please, let's submit more. Wow. I'm loving this. Informative, CHV, play a key role, innovation. So we'll still open the Menti portal. So continue giving us responses, continue telling us a lot about what you've learned, what you've seen, and you can still go back to your sticky notes and make those points, and we can be collecting them later on. So at this juncture, I would like to recognize the presence of two important people who joined us. One is Dr. Carol Ngunu from NMS. She's in the Deputy Director, NMS, Nairobi County. Thank you so much for joining us. And Dr. Macharia, if you're in the house, Dr. Macharia. Thank you so much, Karibu. He's representing us from the HPT department. Thank you. So at this time, I think we would be ready for our first break. We need to replenish. As you move out for our tea, please remember it's 15 minutes and we'll be at the tables for demonstrations. For those of us who did not have an opportunity to visit the problem master and the solution tables, this is an excellent time for you to pass by with your cup of tea or coffee so that we can interact more, get to know each other, and see some of the innovations that we have lined up for you. Thank you very much. So, timekeeper, we have 15 minutes for tea. So when are we coming back? 11:18 we'll be back. So let's all ensure that by 11:20 we are all seated so that we can move on to the next session. Thank you.
It always seems impossible until it's done. InSupply has adopted a new approach to improving competency within supply chain by developing virtual learning packages that help impact teams perform more effectively, what we call the IT learning packages. The learning packages are online-based courses designed to meet the needs of teams focused on promoting competency building. The impact team is InSupply's signature approach of structured supply chain data use in problem solving and action planning. This approach helps health workers improve data quality and commodity availability through communication, coordination, and collaboration. It is a multidisciplinary quality improvement team comprised of 7 personas that enable the team to be operational, effective, and sustainable. These are Organizing Otto, Peter Problem Solver, Data with Diana, Supply Chain Sam, Influencing Irene, Resource Rita, and Lucy Leader. The learning packages have been developed for each of the personas, accessible free of charge online by the impact team members using a smartphone, laptop, tablet, or a desktop computer. To learn more on how to navigate the learning packages, please check out our tutorial video for more details. Never stop learning, because life never stops teaching. By now you know about the learning packages course online. It always seems impossible until it's done. To access the portal, simply key in www.scdatause.org. That is www.scdatause.org on your browser, then press enter to log. By now you know about the learning packages course online. This video is going to take us through navigating the Impact Team portal. To access the portal, simply key in www.scdatause.org. That is www.scdatause.org on your browser, then press enter. To log in into the portal, key in your username and password, which will be provided to you by InSupply Health. In case you forget your password, simply click on the Reset Password tab. Enter in the email used to register, then click Submit. An email with the reset detail will be sent to you in due time. Once on the home page, click the Learning Packages tab. The Learning Packages option will appear as shown. Next, select the learning packages you'll want to learn by simply clicking on the View Training button. Once you select the View Training button, this will direct you into the course. To begin learning, click on the Start Course tab as shown. When you pause your learning and need to resume from where you left, or need to go back to the previous section of your learning, use the scroll bar on the left as shown to move up or down. At the end of every learning package, you can access additional resources by simply clicking on the resource link provided of the resource you want. To get certified and reinforce your knowledge further, click on the Get Certified tab, which will direct you to the Google quiz page. Once on the page, click on the respective course tab. This will direct you to the Google form for the test. A certificate will be provided once you attain a score of at least 80% in your test. You may retake the quiz up to a maximum of 3 times. After completion, you will receive your results through an email and a certificate shared after. Once you are done with the learning packages of your choice, we'll go back and access other learning packages, which include Organizing Auto, Beta Problem Solver, Data with Diana, and Supply Chain Sum. For more information, kindly visit our website at www.insupplyhealth.com or email us at info@insupplyhealth.com.
InSupply Health Limited, transforming lives by co-creating innovative and sustainable solutions for healthy communities.
That help impact teams perform more effectively, what we call the IT learning packages. The learning packages are online-based courses designed to meet the needs of. It always seems impossible until it's done. InSupply has adopted a new approach to improving competency within supply chain by developing virtual learning packages that help impact teams perform more effectively, what we call the IT learning packages. The learning packages are online-based courses designed to meet the needs of teams focused on promoting competency building. The Impact Team is InSupply's signature approach of structured supply chain data use in problem solving and action planning. This approach helps health workers improve data quality and commodity availability through communication, coordination, and collaboration. It is a multidisciplinary quality improvement team comprised of 7 personas that enable the team to be operational, effective, and sustainable. These are Organizing Auto, Beta Problem Solver, Data with Diana, Supply Chain Sam, Influencing Irene, Resource Rita, and Lucy Leader. The learning packages have been developed for each of the personas, accessible free of charge online by the Impact Team members using a smartphone, laptop, tablet, or a desktop computer. To learn more on how to navigate the learning packages, please check out our tutorial video for more details. Never stop learning, because life never stops teaching. It always seems impossible until it's done. InSupply has adopted a new approach to improving competency within supply chain by developing virtual learning packages that help impact teams perform more effectively, what we call the IT learning packages. The learning packages are online-based courses designed to meet the needs of teams focused on promoting competency building. The impact team is InSupply's signature approach of structured supply chain data use in problem solving and action planning. This approach helps health workers improve data quality and commodity availability through communication, coordination, and collaboration. It is a multidisciplinary quality improvement team comprised of 7 personas that enable the team to be operational, effective, and sustainable. These are Organizing Otto, Peter Problem Solver, Data with Diana, Supply Chain Sam, Influencing Irene, Resource Rita, and Lucy Leader. The learning packages have been developed for each of the personas, accessible free of charge online by the impact team members using a smartphone, laptop, tablet, or a desktop computer. To learn more on how to navigate the learning packages, please check out our tutorial video for more details. Never stop learning, because life never stops teaching. It always seems impossible until it's done. InSupply has adopted a new approach to improving competency within supply chain by developing virtual learning packages that help impact teams perform more effectively, what we call the IT learning packages. The learning packages are online-based courses designed to meet the needs of teams focused on promoting competency building. The impact team is InSupply's signature approach of structured supply chain data use in problem solving and action planning. This approach helps health workers improve data quality and commodity availability through communication, coordination, and collaboration. It is a multidisciplinary quality improvement team comprised of 7 personas that enable the team to be operational, effective, and sustainable. These are Organizing Otto, Peter Problem Solver, Data with Diana, Supply Chain Sam, Influencing Irene, Resource Rita, and Lucy Leader. The learning packages have been developed for each of the personas, accessible free of charge online by the impact team members using a smartphone, laptop, tablet, or a desktop computer. To learn more on how to navigate the learning packages, please check out our tutorial video for more details. Never stop learning, because life never stops teaching. It always seems impossible until it's done. InSupply has a It always seems impossible until it's done. InSupply has adopted a new approach to improving competency within supply chain by developing virtual learning packages that help impact teams perform more effectively, what we call the IT learning packages. The learning packages are online-based courses designed to meet the needs of teams focused on promoting competency building. The Impact Team is InSupply's signature approach of structured supply chain data use in problem solving and action planning. This approach helps health workers improve data quality and commodity availability through communication, coordination, and collaboration. It is a multidisciplinary quality improvement team comprised of 7 personas that enable the team to be operational, effective, and sustainable. These are Organizing Otto, Peter Problem Solver, Data with Diana, Supply Chain Sam, Influencing Irene, Resource Rita, and Lucy Leader. The learning packages have been developed for each of the personas, accessible free of charge online by the Impact Team members using a smartphone, laptop, tablet, or a desktop computer. To learn more on how to navigate the learning packages, please check out our tutorial video for more details. Never stop learning, because life never stops teaching. It always seems impossible until it's done. InSupply has adopted a new approach to improving competency within supply chain by developing virtual learning packages that help impact teams perform more effectively, what we call the IT learning packages. The learning packages are online-based courses designed to meet the needs of teams focused on promoting competency building. The impact team is InSupply's signature approach of structured supply chain data use in problem solving and action planning. This approach helps health workers improve data quality and commodity availability through communication, coordination, and collaboration. It is a multidisciplinary quality improvement team comprised of 7 personas that enable the team to be operational, effective, and sustainable. These are Organizing Otto, Peter Problem Solver, Data with Diana, Supply Chain Sam, Influencing Irene, Resource Rita, and Lucy Leader. The learning packages have been developed for each of the personas, accessible free of charge online by the impact team members using a smartphone, laptop, tablet, or a desktop computer. To learn more on how to navigate the learning packages, please check out our tutorial video for more details. Never stop learning, because life never stops teaching. It always seems impossible until it's done. InSupply has adopted a new approach to improving competency within supply chain by developing virtual learning packages that help impact teams perform more effectively, what we call the IT learning packages. The learning packages are online-based courses designed to meet the needs of teams focused on promoting competency building. The impact team is InSupply's signature approach of structured supply chain data use in problem solving and action planning. This approach helps health workers improve data quality and commodity availability through communication, coordination, and collaboration. It is a multidisciplinary quality improvement team comprised of 7 personas that enable the team to be operational, effective, and sustainable. These are Organizing Otto, Peter Problem Solver, Data with Diana, Supply Chain Sam, Influencing Irene, Resource Rita, and Lucy Leader. The learning packages have been developed for each of the personas, accessible free of charge online by the impact team members using a smartphone, laptop, tablet, or a desktop computer. To learn more on how to navigate the learning packages, please check out our tutorial video for more details. Never stop learning, because life never stops teaching. It always seems impossible until it's done. InSupply has adopted a new approach to improving competency within supply chain by
I think I had promised that if we have people who are tweeting, retweeting, they will get something. I am looking at our Twitter handle. Did you tweet something? Are we seeing any tweets that are calling out at InSupply Health? Let's see who are these who are tweeting. If you want to rig, you can rig now. I want to award someone who's tweeted and someone who is retweeting. Can I see? I've seen a post that is capturing the bottom-up data utilization, which I think it's worth retweeting. If you're on your Twitter page, let's see. There's someone called Vera Kish. Vera, is Vera in the room? Vera is online. If we can find out whoever is managing the online team, if we can find out where Vera is coming from, we will give them a gift. Then there's someone else called Njeri Karaoke.
Hello.
Njeri, wow, Njeri is here. So Njeri gets something.
Hello, Vera Kish. Sorry.
Vera is online.
Vera is following us from Siaya County, Ugenya sub-county. Is our sub-county nutritionist.
Wow, Vera, we will make sure Dr. Abuya carries something for you. Yeah? So thank you, Vera, for tweeting, retweeting, and Jerry here also gets something. Congratulations, Jerry. Keep tweeting, keep retweeting, whatever you had that was useful that you think the public can, this is information. We don't just want to leave it in this room. We want the public to also know about it. Okay. Okay, Sawa, thank you. I understand there's a question from one of the online participants. And this question is directed to George Okello. George, please respond. Tell us the question and respond.
Thank you very much. We appreciate our participants who are streaming live. And the question from Turkana was from the RH coordinator asking, how has InSupply contributed to the RH indicators in Turkana? I'm going to answer this in two folds. One, from the CHV perspective, and secondly, from the sub-county and the county perspective. So for the CHVs, the approach that had been taken that Afya Timiza had hoped for was to train the CHVs to deliver and administer family planning commodities at the household levels. And this had been collaboratively done with InSupply in Samburu County. And the next county was Turkana County. Unfortunately, we were unable to see that project to fruition. So one of the ways that InSupply could have contributed to the RH indicators at the community level using the CHVs would have been through the CBDs, where the CHVs would administer DMPAC. But now on the sub-county and the county level, we are talking about impact teams, and specifically to the family planning dashboard that provides us with visible data that can guide us on making decisions. So the ITT provides data that is very easy to use, and this has been utilized by the sub-county and the county teams to ensure that there are action points that are taken, including redistribution of family planning commodities and product availability at their county and sub-county stores. Thank you.
Thank you, George. Online participants, please keep engaging us, ask your questions, make your comments. We recognize you, and we will keep recognizing the comments that you're making. So now we want to move to another session. We have heard a lot from the community. We only heard from 3 counties. We didn't hear from Mandera and Wajir, but they are going to make a commentary after this. Just a few comments on how they feel CSTOC has contributed to commodity management, to supply chain management at the community level. So just prepare to make one comment on that, Mandera and Wajir. Thank you. Right now, we want to go to recognition, reward and recognition. We are human beings, right? And as human beings, we really like to, when you're appreciated, you feel nice. Yeah, when your work is appreciated, you feel nice. This is when we were conducting our human-centered design research, we realized that motivation is one of the key aspects of motivating human beings to perform better. So the counties and sub-counties and the communities have devised ways of recognizing their members in different ways. Some are low cost as thank you, you've done well. Another one, sending a message through their WhatsApp groups, or their leader recognizing them. Those are some of the ways they've been recognizing them. And today we want to also enforce some of that to appreciate the work that our counties, sub-counties, communities have been doing. And the first category we will look at is the learning packages. As you are walking in, we walked you through what the learning packages are. When COVID came, we realized that we cannot continue physical trainings, right? But learning could not stop. So we came up with some learning packages that would help our teams continue building their capacities. So that is where we started. And it was an uphill task to get people to take up these learning packages. And to date, I can tell you the uptake is really commendable. And it's focusing on building different skills, supply chain, organizational skills, problem solving, data visualization and analysis. And we've seen quite commendable uptake in this. So I just want to recognize some of the counties that have made efforts to take on the learning packages. And we will start with the first county award. And as we are bringing on these awards, we recognize some of the people who contributed to this are not in the room. So they are representatives. We urge you, when you get this award on their behalf, please take it to them. So it's an award towards their achievement. The first category, and I want you to be happy as these people are getting their awards. So mshangilia kabisa, tayarisheni mikono. Yes. Okay, the first award, this goes to the county with the highest proportion, with the highest proportion of impact team members that have been certified on the learning packages. So you're looking at the impact team members. If an impact team has 5 members and all of them have been certified, you have 100% certified on the learning packages. That's the county we want to recognize. And today, our winner from the scale county is, can you guess? Drum rolls. Samburu County. So I would like to request Dr. Salim to please come and award Samburu County and a representative from Samburu to come and receive this award on their behalf for having the highest number of impact team members taking on the learning packages. So the second award for the data use county, it's already on the screen. Trans Nzoia County. This is my county. I am very proud of them. At the beginning, it was an uphill task to get them to start learning, but they eventually picked up the learning, and congratulations to them. Miriam, please, if you can bring the trophy for Samburu County. And so Dr. Salim here will assist us in awarding Samburu County. You can pass the trophy to Samburu County. Dr. Salim, you can read for us what it says.
Best Supply Chain Impact Team in Samburu, awarded by In Supply Health.
Yes, Samburu, congratulations. The next one is going to Trans Nzoia County. Thank you, Samburu. Trans Nzoia are here. Please move ahead to this. Miriam, if you can bring the trophy from Trans Nzoia. They are represented by almost the whole CHMT.
So Best Supply Chain Impact Team in Trans Nzoia.
Congratulations, Trans Nzoia County. Yeah. Okay, thank you. So the second category is coming to the best impact team on learning packages per county. So we are choosing the best 3 in your in each project. We are looking at the best 3. So the winner in the scale county is Tarbaj Impact Team. So if we can have Wajir. Actually, Wajir is taking all this award. There's Tarbaj, second runners up. It's not that, it's the certificate. the city certificate. So Tarbaj, then Wajir North, and then Wajir West. They are represented here. Okay, as our team is looking for where their award is.
Just bring that cup. I won't put the name of the county.
We want to recognize that we had also done some recognition to some of the scale sub-counties. And so the award you're getting today is a ceremonial award. Okay? Thank you. Yes, I can see they're back there. So for Wajir West, Wajir North, and Tarbaj, if we can hurry up, please. Wajir North, then we have Tarbaj. Tarbaj, who will hold for Tarbaj? Okay. Wajir North. Tarbaj, and then Wajir West. Well done, Team Wajir. They actually had 100% of their impacting members taking up the learning packages, which is quite commendable. Okay, for the data use counties, the ones who had their members taking up the impacting packages, I will start with the second runners up is Cherangani Sub-County. Cherangani Sub-County, if we can have one of the county members represent Cherangani. Second runners up ni number 3 on the list.
No, hata Cherangani imekuja plus.
Yes. Cherangani, I hope you hang that proudly on your wall. And the online participants from Cherangani, congratulations. And the first runners up, that is number 2, goes to Mombasa, Changamwe Jomvu. Simchangamkie Changamwe Jomvu, jamani. Changamwe Jomvu, they will be getting a kettle so that when they're having their meetings, they can brew some tea. Changamwe Jomvu.
Hata afadhali ungewapatia fridge. Wao niko na joto.
Dawa ya moto ni moto, ndio hiyo. Dr. Hanifa shasema. Thank you, Changamwe Jomvu. And the overall winner, wait for this. Thank you, Changamwe Jomvu. Congratulations even to the ones online. The overall winner for this category for data use county, drum rolls. I'm looking in that direction. Niona wechangamka. Embakasi East and South. That is from Nairobi, and they get a microwave. Congratulations, Embakasi team, represented by Dr. Maore and Bwabi. We have Esther Kiambati from their HMT team. Congratulations, team. Okay, I will do the last one and then we go back to the presentation. This goes to individual members. Yeah, individual members who have taken up all the 4 learning packages. Please allow me to remove my mask. So individual members who have taken up all the 4 learning packages, there are quite a number. There are 39 of them, but I want to call up the ones who are represented in the room so that they at least feel recognized. So we have from Samburu Central, Joseph Rotich. Is Joseph here? Congratulations, Joseph. He has taken up all the 4 learning packages. Then we have Dr. Kerry Abuya. Kerry, congratulations. Followed closely by Dr. Juma Baraza. Dr. Juma Baraza. I'm just calling the ones who are here. I don't know if Abdi Ado Eden is here. Oh, Abdi is represented? Okay, Abdi, you can take on behalf of Abdi. But also just to recognize, Wajir had the highest number of, Dr. Baraza, please, that one is for you. He's taken up all the 4 learning packages. Congratulations. And Abdi is going to represent the Wajir participants. They've surely done well. They took up, not only did all their impact team members take up the learning packages, they took up 4 learning packages, each of them. Congratulations to them. So the individual awards, the 39 of them, will go directly to the counties. We have the list of these members who have taken it up. Thank you very much. Dr. Salim, thank you. You may sit down. Okay. I think that was exciting. Do you feel good about it? There are more prizes coming up. So if you did well, prepare yourself to stand and take a nice photo, yeah, and be excited about it. So up next, I will welcome Janet McKenna, one of our colleagues from InSupply Health, who will just talk about the impact teams at the county level, the sub-county level, and then welcome the counties that have been implementing impact teams to make their presentation. Over to you, Janet.
Thank you so much, Judy. And congratulations, yeah, like Judy has said, it's great to see the motivation and the excitement in the room, yeah, as we celebrate our wins. So we'll move over. We started with the spotlights for the scale counties, and now we want to hear from the data use counties, yeah, the other 4 counties where we've been implementing. And for the data use project, we have been focusing on rolling out the impact teams. And these teams were mainly active at the sub-county level, where the teams are constituted, and on a monthly basis, they used to review their data just to ensure that they are monitoring their supply chains with an objective of improving its performance. So we'll hear from the counties who will be telling us about the things that they've been able to do. So we'll hear about the impact teams, the indicator tracking tool that they have been using and their experience around it, the learning packages that we've just seen some of our members getting their awards around, and also something called potency that we will hear about, and how potency was used for cold chain equipment monitoring or tracking the performance of the cold chain equipment in Mombasa County. So we'll have the counties come up and share their experiences and their successes in this order. So Trans Nzoia will be the first county, and they'll be followed by Nyeri County. Then after Nyeri County, we will have Nairobi County, and then Mombasa County. And just like we did in the morning, we'd like to capture some of the opportunities and gaps that will be popping up as the presenters will be sharing their experiences, so that as we come back to the next session in the afternoon, we can be able to revisit these opportunities and gaps and use them for planning for our sustainability. So without much further ado, I'll welcome Dr. Baraza from Trans Nzoia to take us through their experiences, their successes, the lessons that they learned, and some of the things that they would want to share.
Thank you, McKenna.
just to check. In the morning, we were told, Kusema Mlembe, what do you say? Mlembe. Mlembe. Mlembe means peace. From Trans Nzoia County, we really appreciate In Supply Health for choosing and partnering with us through this journey of improving our supply chain using impact team approach. I also thank our members who are here and those who are who are following online for making the impact team approach a success in our county. If you look at from the start, the journey for impact team started about 2 years ago when the team from In Supply Health visited us in our county, led by then Wamboi Waithaka, to sign the MOU. We had our trainings, and from the problem statement, sub-county teams had a lot of supply chain data collected every month at the health facilities. The need to have quality data for decision-making at all times has proven to be a challenge, as most of the staff do not understand the magnitude of decisions made with poor quality data. Most of the time, you realize that staff were just reporting for the sake to complete the reports, but they didn't know that the data is also being used for supply chain, like it's already happening with the malaria. Data in the DHIS is used to determine what commodity comes. There's the knowledge gap among service providers, which was also coupled with the non-routine support supervision by sub-county health management team. And this is what upheld the problem, as it was easy to identify and respond to the emergency issue. When we started, our reporting rates were as low as 60% for family planning. There was poor data quality, incomplete reports or reports with the variance, that is ending and beginning balances. Like in March, the variance was at 86%. We had high stock out rates at the facilities, high wastage of vaccines, and low vaccine coverage. IMPACT is an acronym which stands for Information Mobilized for Performance Analysis and Continuous Improvement. So the sub-county impact teams is formed by a dedicated team of sub-county management members who ensure that all data, especially for supply chain, meet all the data quality dimensions. That is the timeliness, completeness, accuracy, relevance, precision, and consistency. The team meets on monthly basis to review the performance of the previous months. The review data extracted, the team usually review the data extracted from the ITT, which is the indicator tracking tool, after which the roles are assigned. Based on the gaps, the team members are assigned themselves the various roles who will take what responsibilities. Roles are assigned to members in accordance to gaps highlighted. Then there is tracking using the action template of who is doing what in relation to the roles assigned. Usually at the end of it, there's usually recognition done during each meeting. Most of the time, it's usually just applause. Since the introduction of the impact team in Trans Nzoia County, we have had a very improved commodity management system. And this is evidence. The national team who are here, I know they share the pager, the 2-pager every month, and they just shared one yesterday. And if you look at the two-pager, you compare the data challenges of Trans Nzoia with our neighbors or any other counties, we only happen to be having a small problem. And this is because of the impact team approach. There is ease in identification of poorly performing facilities using for those who are outside there, you are taken through the tool. You can trickle down to the facility that is having issues. Enhanced analytical eye. Before someone does data entry in the KHIS, like it was highlighted some time back, you realize that a facility has reported 5,000 condoms. When you talk to that staff, they get confused. Even they disown their data. But after that, next time they don't repeat the same mistake. Improved reporting rates and timeliness, reduced wastage. Then there's increased vaccine coverage. Ownership of the indicator by all the team members. Previously, before the impact team approach, people used to engage in blame game. So that whenever there are problems, everyone disowns it, no one wants to be associated with the problem. But with the time, people realize that making mistakes is not a big mistake. You own up the mistake and start the journey to correcting. Shared there is part of some of the snapshots from the indicator tracking tools. And you can see as a sub-county like Saboti, we just picked a few. A sub-county like Saboti, they moved from January from 91%, that is FP, to 100%. For immunization, you can see the vaccines, the absolute percentage difference. In March, we were doing badly, but by September, we had actually improved quite significantly. So experiences, team building, from the impact team, people realize that it's important to work as a team, and they realize that it's good when each and every member is appreciated and given a certain role. So there was that team building of the team, work spirit among the team impact team members. Monthly data review meetings have been happening. There's improved problem solving skills using the RCA, capacity building. From the awards, you've realized that most of so many members from Trans Nzoia have taken their impact the packages. In fact, feedback from Trans Nzoia, they are saying, what of the 3 remaining personas? There are those who are already excited, they want to do the other packages that are not yet in the system. Attendance of indicator on impact team meetings by CHMT representative. So far, 4 members usually attend those meetings. Action planning, tasking of specific members of an action, which they follow up and they give feedback in the subsequent meeting. Then there was an improved commodity availability at the facility due to proper forecasting. What was our challenge is issues to do with the redistribution, that is a transportation of commodity. COVID came with these virtual meetings. It took time for some members to adjust. Then the issue of, in those impact team meetings, how do you award those who have improved? There was a challenge in that area. Lack of coordination, airtime, especially when you need to follow up on an issue at a facility. Then what we realize is that you sort out a problem at a facility, then another facility develops the same problem, but with the time they keep on reducing. So that is where the recurring problem is, even after being addressed. That is a photo. You can see one of our directors. That is those who know Brian from In Supply, and at the far corner is our CEC for health. Lesson learned, proper understanding of key performance indicators and consistent data review is key in improving and maintaining good key performance indicator. Then use of data in decision making improves performance. scheduled, consistent data quality assessment, such as the platform provided by Impact Team, improve the availability and quality of data of an organization. Teamwork is key in achieving agreed upon actions. Feedback and deliberations is important for implementation of action plans. Follow-up on action points is important in ensuring their implementation. Support supervision is not the only effective way, because previously people used to go for support supervision without knowing what they are going to address. So the Impact Team approach, where you look at the data before you go for support supervision, came in to improve. Every team member has a role to play, and lack of motivation is a silent killer. Thank you.
Thank you so much, Dr. Baraza. Now we'll welcome Dr. John from Nyeri to share with us their experience. Okay, and the timekeeper reminds me that we need to stick to the 5 minutes that we all have been.
Testing. Thank you, Lady Janet. I come with greetings from Nyeri County, from our Governor, Edward Mutahi Kahiga. And he sent me to tell you that if you are a native of Nyeri County, to make sure that your vote is current, so that when the time comes, you can vote for him. So I'm here to present on behalf of Nyeri County. I hope it is okay. Now, of course, we all know what IMPACT stands for: information mobilized for performance analysis and continuous transformation. We know that cycle, data management cycle of collection, collation, review, in order to take action and make decisions. Well, we know impact is about technology and data, people, processes, as well as principles or policies. But our county is more people-centered. Where we say our slogan is all about you. Those are our 8 sub-counties in which we have had or currently have impact teams. No need to mention them individually. Now, that's just a brief on when we talk about people-centered, what we mean. We value our partners, including in supply. Of course, we have leaders like our governor, we have our CEC and Chief Officer and Director of Health. We also have our providers who have been performing or providing exemplary services to our beneficiaries. Oh, this thing is so unstable. Who, of course, are our main focus in health service provision. It's that one. You know, the clock is ticking, so I'm kind of Oh, Janet, she's offered to hold the cable for me. Okay, now problem statement. Data use for decision making has become a top priority at our level, including the national level. Of course, you know Article 6.1a. We have two levels of government that collaborate and work consultatively. So the two parameters that form our problem statement are data quality as well as the reporting rates. So some of our problems include lack of ownership at the facility level regarding their data, lack of in-depth data review. As we said, that the data management cycle of collation, compilation, review, as well as taking action. In that regard, we had poor ownership prior to impact coming in supply health coming into our county. Lack of in-depth data review in those meetings that have since been set up and have been regular. Poor data quality insofar as accuracy, completeness, and timeliness in reporting. So now these multidisciplinary teams have had this forum created where they have been reviewing data in those meetings. So of course, the cadres we're talking about here, HRIOs, nursing officers, both at the facility as well as the sub-county, and pharmacists or farm techs at the sub-county level. So of course, the two programs we're talking about with regard to in-supply and how we've been collaborating in the county and sub-counties in Nyeri, or the planning or family planning and immunizations. Some of the best practices would include the holding of meetings. And of course, in this era of COVID, these meetings have been virtual. So the practices, so far as best practices are concerned, would be action planning and sharing of minutes in good time. Prior to in-supply coming in, you would have those minutes tarry for even as long as 1 month until the next meeting would be held. But now these ones are shared almost real time after those meetings are held. So basically, the streamlining of this has meant that we have had improved reporting rates, data quality for decision making, and improved health outcomes insofar as mobility, decreasing mobility and mortality is concerned. Of course, you know, the ultimate impact of our activities in healthcare service delivery would be, as they say in the Kenya health policy, that every person has a right to access the highest attainable standard of health, including reproductive health services. So this ITT, or indicator tracking tool, has enabled us to easily access key supply chain indicators for those two programs. And we're able to address overstocking and understocking issues and subsequent redistribution thereof. Our innovations have included those learning packages that we've had several counties lauded about. This would include those that have underlined organizing autos, supply chain SAM, data wiz, and PITA problem solving. The tools that have been introduced include ITT, IT minutes templates in supply link to dashboard. As we said, there's a connection and visibility between the dashboard as well as KHIS. And of course, the action plan template that is a result of those meetings that are held. The eventual impact has been the structured or systematic way of performing data review and meeting effectively for continuous quality improvement, as well as increased accessibility to and visibility of data. Now, insofar as reporting rates and timeliness, before we go to data quality, I don't know if you can see that key up there, but the line graph in blue talks about final reporting rates. And the red, no men are said to be colorblind, but the red represents timeliness. So at baseline, or at the beginning of the program in supply health in collaboration in Nyeri County, our reporting rates as well as timeliness was about 88 to 90%. And now currently we are at about 95, 96%. So that is a market improvement when you consider that it's always a lot more difficult to move from a high index to higher still, to get closer to 100%. So 88 to about 95, 96% for the two data streams. Now, data quality, insofar as data quality is concerned, there's something called absolute performance difference, so that the closing balance of, as we said, the two programs, FP and immunization. So we were comparing the closing balances in each of the facilities of each of those FP or vaccination or immunization commodities, so that the absolute performance difference should be less than 10% between the closing balance, which we call balance carried forward, and that brought forward in the next month. So if that difference was less than 10%, then we would take, of course, the ideal is less than 10%. Yeah. One more minute or two. So as you can see, there's been a continuous quality improvement in this regard, because more and more facilities over time have been decreasing that disparity between their closing balances of 1 month and the subsequent month. So you can see the trajectory there with regard to COCs, combined oral contraceptives, and the long-term methods. Then experiences, our challenges are those ensuring that we have a common day for reporting when they bring the reports, counter-checking previous reports against current reports before entering into the DHIS. That is a mark of improved quality. Added level of data visibility help ensure that commodities are in most facilities through distribution and refresher trainings, of course. Those learning modules we talked about, and our challenges are those. Not all of them, of course. All facilities within the sub-counties have been submitting the reports as laid out. Rotation of staff, of course, because there's loss of institutional learning and memory when there's no proper handing over, orientation of new staff, and lack of commodities in facilities. As we know very well, for program items, there has been some politics with regard to taxation. It's also affected FP, not just HIV commodities. Those are our lessons learned in the multidisciplinary teams. There's been increased cohesiveness, best practices, regular data review. And that is about it. Of course, I have team members, county nursing officer, the RAMCA coordinator, and the farm tech in charge of our county buffer store, to whom you can address questions. Thank you.
Thank you so much, Dr. John. So we'll move on to hear from Nairobi County and what their experiences were with the learning packages. No.
Good morning, or is it afternoon already? This is the NMS team. As we're setting up, I want to appreciate JSI for the In-Supply Health for partnering with us. It's been a blessing for our county because most of our sub-counties are having the IT teams, the impact teams. And from those teams, there's been an improvement on our reporting rates, on our timeliness, and even the quality of data. Okay, so I'm going to present on learning packages. And already you've seen that Wajir did very well. And I'll be sitting with them to know how come they were able to do the packages all together. Shows that maybe they have teamwork or something, or there's someone there encouraging them to do the packages. Because sometimes you ask people to do, and they might not necessarily do what you're saying. So the problem statement here, before the rollout of the learning packages and the role profile assessment, we relied on one person or an individual who used to be doing the coordinating, planning, and facilitating the meetings. But in their absence, sometimes the meetings actually don't happen. I think it's maybe a problem to even other counties. So that was our main problem. So there came about the learning packages after the impact team or the notion came about from InSupply Health. So the learning packages, as we've seen, we've had again previously, is a self-directed online-based modular. So there's a course, I'm going to show you what it's all about, just an introduction to it. It's online, you can go in there on any time and access it, and you're able to learn different things from it. And who is targeted to do it? The impact teams members from the sub-counties are target and the county, data review teams and supply chain commodity management teams. And I feel like it goes down even to facilities, because at any given point, you really need these skills, be it data analysis, be it organizational skills, everyone needs this. So it's not only the teams, but anyone can interact with it. And the reason for this is to build capacity for teams to ensure that we improve our health supply chains and perform the tasks better, optimally, through the use of the data for decision-making, problem solving, and action planning. So the learning packages, why the learning packages? As I've already said, it's going to help one have competences, skills, and knowledge that is required for data review teams. And we know that data is important at all levels. You need to interact with the data that you have and be able for it to tell you what kind of trend do you have for a question that you have, for a problem that you have to solve it. So they are centered in 4 main core role profiles. We have the organizing, we have problem solving, we have the data, I'm tempted to call data Diana, and supply chain. And then we have enabling or support members also, who are influencers, who are the people who go know where the resources are, go for them, and the leader. So the organizing person is the person who calls for the meetings, ensures logistics are in place, tells you where the place is, the agenda, and ensures that the minutes are shared on time before you start the meeting, which I thought was very important, a very important person or role there, to have an organizer for you to actually hold a meeting. So in the current roles of the people I believe seated here as leaders, organizing should be you. If you're not organized, then there are things that will pass that are important that you didn't take note of. So the problem solver is the person in the team who's always asking, but why? Why did that happen? Why can't it be this way? So a very good thinker there who steers the meeting and ensures that the actions are there and practical next steps in terms of making your actions. Then data whiz is the person who understands what your indicators are. They're able to interpret them. They're able to pull data from what we're able to see from ITT, what was presented. The KHS data we feed is pulled to the ITT, and from there you're able to get graphs and things that you can be able to use. So data is very important. And I believe as a manager where you are, you need to understand what your data is, what indicators you have, and how you're performing. The supply chain also very important, who understands the supply chain processes and is able to identify where the problem is in the process. Yeah, so the influencer is the person who ensures that everyone is okay, influencing some of those good ideas that you have, ensuring that they are taken seriously at the end of the day. Then the resource person knows what money you need, where the money is available, how they can advocate for it and be able to get it. And we know that resource is important in moving forward. And then the leader, of course, is the one holding everyone's hands and moving. These are the learning packages for the Nairobi team. Organizing auto was the most popular. Myself have not done it, but from what we had out there, I think I'm going to ensure that I do it. But the others are supply chain, problem solving. You can see how we performed, DataWiz being the least. The sub-county which performed well in terms of the uptake, which has the microwave there, is Embakasi East and South sub-counties. So our experience, what has worked well, we're now able to develop an action plan with goals. You know how the minutes are, how the tool is for minutes, which I really love. You're able to get an action plan for the previous and the current one, which you're doing, and you're able to follow through. And it is very simple and very targeted, which I find very useful. Then teamwork, support, and encouraging one another to take up the learning packages really worked well. We were able to post these certificates on WhatsApp. We had the support of the SCHMT and the sub-county MOH. Of course, motivation is just encouraging one another. Have you done this? I've done this. It's interesting. Take it up. Things like that. And then identifying a champion, which I think is very important, who says, Lawrence has done, Beatrice needs to do it, someone else needs to do this one. I think this is your strength. You need to take it up. It was very good. So some of the challenges were the time constraints and the technological issues in logging. So the benefits of having the learning packages, I'm hoping that I'm going to infect all of us to be able to take up the learning packages. So ownership of the impact teams meetings by the teams, sharing the meeting schedule early enough before and the agenda before you start the meeting is important. And how you have the data before you've had, you can even share the information before about how you've performed. Someone looks forward to come and they even have answers to why they've not performed very well, where they have not performed. So it's really encouraging and people come prepared. Then strong teamwork across different programs. And in our impact team, we co-opted different people, not only the core, we had co-opted some members. So everyone handling HPTs was in the team. So it also served as our TWG, and we were able to identify everyone's role according to the learning packages and strengthen those ones. So the role distribution, yes, improved time management, because we will decide we'll do a 1 hour meeting, 2 hours meeting, and we will adhere to that. Then individual responsibility and accountability in meetings, also it's very important. So personal commitment and self-drive among the members was actually there. You can see in that photo, there is a team member who's from the sub-county encouraging the staff on some knowledge and skills. And what I personally did was to share like the minutes tool. You go to a facility, you see minutes there, it's so much narrative, but you can't pick out what someone was saying. So that was important to, I encourage someone, use this template. It's more directed. You can be able to, move forward on wherever you action and follow easily. So also knowledge and skills upgrade to mitigate individuals and team gaps. That worked very well during the assessment. We did an assessment at the beginning to see who can perform which role better, who is an influencer, who's the leader, who will be helping us with this, and that ensured that we had regular meetings. Then some of the lessons that we've learned, we know that the packages are self-driven. So this self-driven creates motivation to effective and efficient work output. And since it is self-driven, I'm seeing that for sustainability purposes, this will be going down to even the new people coming into the workforce. We will ensure that they go through some of these packages, which are very helpful, especially supply chain, DataWiz, Diana, and all that, especially for the pharmacy team to ensure that they understand those basic things. Then data analysis and management creates a platform for effective change plan, which is decision making. So true, because what Janet was able to do for us and the team come up with that analysis. So we were asking at some point, when you leave, how will we be doing this? Because we were doing the meetings because we could visualize what's happening, and we were able to learn from the data with Diana. Then knowledge and skills acquisition sustains improvement in quality care through continuous mentorship and support supervision. Because you go to a facility and tell them, you have data, you have the analysis there, you tell them this is how you're performing, this is the quality of your data, this is the variance, this is why you overstocked, how can we improve that? And it was really good. Thank you very much. A minute, please. Then teamwork is key to behavior change and individual responsibility. I believe without teamwork, the impact teams wouldn't work because everyone is busy at some point, but the online platform really came out for us and the teamwork. Then, and even the microwave, I think we will be warming the food together there to share it. So it's very good. And the tea that we actually make mandazi and mahindi come with it to the meeting to ensure that we full as we work. So that's very nice. So target setting also, it's good, and work planning to ensure that we achieve our goals, and you set something and move towards it and able to do it. And then motivation and appreciation of team members. I think it's good when you are told even well done, that's done well. I think you can do better, and you've done very well. Anything that is encouraging goes a long way. Then delegation of the roles. After we did the identifying who does what, we're able to share it all together. You feel among the team, and you feel very good to do something together with other people and have a role as well. So thank you very much. I think that's what we have. So you can see our team there. I'm somewhere there in green. Yeah, so that's the thermos tunatumianga hiyo kubwa, na mandazi I think iko hapo nyuma. Yeah, thank you very much.
Thank you so much, Dr. Nora. I think we are seeing the team that already has planned to start using their gift, yeah? The microwave will not get any dust. So as we welcome Mombasa team to wrap it up for us, I'd like to remind us, and I'm hoping that we are documenting some of the opportunities that we are identifying and some of the gaps that we're identifying using our sticky notes, because they will be resourceful in the next session that we will be going into. So just take a minute and document some of the gaps or opportunities that have come up here as you are hearing from the 3 counties. Welcome, Jewa.
I believe it's afternoon. Good afternoon. Yeah, my name is Isaac Jewa. I'm the county EPI logistician for Mombasa. And I'm here today to present a very interesting project and the vaccine potency. We all know without potent vaccines, there's no program, is it? So in Mombasa, we have been involved in trying to maintain the potency of vaccines and trying to visualize what happens in the facilities. So temperature monitoring has been always a hurdle in provision of quality immunization services in the county. We are using the FT2, and in some devices we are using the RTMs. RTMs are remote temperature monitoring devices. But for the FT2, you cannot get real-time data. You have to go to the facility to be able to identify whether there was a problem. So that has been hurdle. The cold chain equipment inventory was also not sufficient. You could not know which facility is using which type of equipment. And therefore, this project has been able to make us identify the equipment that is in the facilities. So the sub-county data review teams could not be able to discuss cold chain situations of the sub-county as there was little data available and accessible to make informed decisions. There is this app called Varo, which is the app that we are using to be able to get data. Varo is a mobile app, has enabled our facilities to capture temperature data from widely deployed the 30 DTR loggers, that is the fridge tags, using an Android phone and a provided OTG cable. We all know what an OTG cable is, isn't it? No. I have a sample. Probably if somebody can look in my bag, there's a sample of an OTG cable. It's a cable that is able, yes, thank you. I hope I'll get 1 minute for, yes. So this is an OTG cable. Basically, it has a USB connector on this side, and this side, it is able to connect to the phone. We have this is a type C, and we also have the type A, the smaller ones that can go in most of the phones. So once you connect this to the phone, and you connect it to the FD2 has a USB. So once you attach it and connect to the phone, and you have the Varo app in your phone, it is able to generate a file. And basically, it is a 60-day file, a PDF file that shows you how the fridge has been behaving for the 60 days. So this file is sent to a Gmail account, and it is submitted to the configured users. The report then is sent to designated users, and then it is analyzed. So the data that is basically summarized, we're able to get the number of hot alarms, number of cold alarms, number of excursions, and the uptime. I don't know whether we know what uptime is. Yes? Basically, our temperatures are supposed to be between +2 and +8. So this is the time that, the aggregate time that the fridge is able to stay in those parameters. Then review of these CC indicators is done monthly by the impact teams, and has provided the teams with the ability to track performance of CC equipment and take time and corrective measures are taken. So this is, after the file is sent, there is this dashboard that is generated through the Pogo DV dashboard, and these parameters are you are able to view them if you have the rights. So for example, this is Mombasa. Mombasa has 6 sub-counties. Basically, this, you can see the map of Mombasa, and these are the sub-counties, and these dots represent the sub-county. So once you click the sub-county, it is able to open the facilities. You are able to see all the facilities that are reporting. So, and it is also able to make a summary of how Mombasa has performed for that period. So for example, this is for, I think it's for, this is a monthly report. So we have 6 sub-counties reporting, and this is based on 70 reporting facilities. So these are some of the results. I wanted to put more slides, but I was told there will be no time, and I can see there's no time here. So the Pogo DV is able to track the number and types of alarms. And this allows the teams to identify fridges that require maintenance. So for example, this is for Mombasa. The orange bar, this one, the first one, shows the total alarms. And then the red bar shows the hot alarms. A hot alarm, basically, it represents an alarm that comes because the fridge has stayed above 8 degrees for, I think, 8 hours. And then the blue is called alarms. These are alarms that happen when the fridge goes below 0 for, I think, 4 hours. Then the FT2 gives an alarm. So this you can be able to track. This is an example of a facility, Mbungoni Catholic Center. The system is able to give you a summary of what is happening in that facility. It had 5.6 alarms. There was no cold alarm. There were 5.3 excursions. The uptime was 94.4%. And this reporting is in 59 days. And it's also able to give you a graphic sort of representation on how the fridge behaves. So you can see the temperatures going up and down, and the red marks shows the alarms that are able to be recorded. So probably this could be because of frequent opening of the door of the fridge, poor positioning of the fridge, and balancing of the fridge, and probably because of power outages. So these problems can be able to be sorted. So experience sharing, what worked? We have very highly dedicated teams which have continually provided feedback for the facilities for corrective action and recognition of good performance, monthly impact meetings which have provided prompt solutions, identified challenges, continuous on-job training on VARO and CCE data collection, which also includes private facilities. As I have said, this report is based on 70 facilities. Our immunizing facilities are 109. So that means there are 39 facilities that are not reporting. So this is still work on progress. We are trying to mentor the other facilities so that they can also be able to report. Formation of WhatsApp groups to communicate with health workers and reminding them on timely reporting. Challenges: many of the FT2 devices are faulty, and with a faulty device, you cannot be able to generate a report. High turnover staff, you train one today, tomorrow they are gone, so you have to retrain. And again, not all immunizing facilities are reporting on VARO. So I think lessons learned: it is possible to monitor and maintain vaccine potency in our facilities if we employ the right technology. So this is very interesting because I sometimes sit on my desk and talk to myself because the data is also talking to me. Impact teams have offered a good platform to review cold chain performance and share valuable experiences. the county leadership will be able to get involved if helpful feedback is shared to them. So thank you.
Thank you so much, Jawa. So we will, because of time, we'll not go into Q&A, yeah? But we would have liked to go into a Q&A session just to have some questions and have some of those counties respond to some of those questions, yeah? So before we move on to the next session, which is another round of awards, we would like to go to Menti. So we'll go to Menti and we will be able to share some of the key things that we have had through this session, yeah? So I'll give you the code. You can just log into Menti before I pull it up. So you'll enter the code 288. The other one.
I think those are how the code was presented.
Okay.
To change. So let's use
the same one.
This one. Let's use this one.
Okay, so we'll use this code 4576 02 61. 4576 02 61, yeah? Very lovely. I'm seeing some hearts beginning to pop up, yeah? So let's hit the likes. Great. Are we all connected? There are 20 people. We'd like to get some feedback on that session. Yes, and that's a question that we'll be answering, yeah? So we'd like to know what was the most interesting thing that you picked from the session. We've heard from Trans Nzoia County, went on to Nyeri County, heard from Nairobi County, and finally Mombasa counties, yeah? And they've all been sharing their experiences on how they've used the different components of the impact teams approach. So what are some of the most interesting things that we picked from the session? I'm seeing the responses are beginning to pop up. The use of the Varo app, motivation and how it's key to ensuring that we're improving our performance, the learning packages and that they are practical and can work. Thank you. The teamwork with defined responsibilities, use of data, a lot of interesting and good responses that are coming up, yeah? Yes, so sometimes someone talks to himself because the data is talking to him, yeah? And how physical uploads can motivate the team. The use of the OTG cables for Varo monitoring. So for West Pokot teamwork spirit distribution of duties with motivation, involvement of top leadership in impact team. I think that was Turkana. Target setting, which is very important to make sure that you're working towards a common goal, yeah? And the role rotation, just to ensure that team members can be encouraged to take up the learning packages. So thank you. Keep those responses coming, and I'll still remind us, let's write the opportunities or gaps that we've been able to identify to just inform the discussion that we'll be having in the afternoon. All right, so at this point, I'll welcome my colleague to take us through the next session for another round of awards. Welcome, Ken.
Good morning, everyone. I wanted just to see how many people are still in morning. Good afternoon, everyone. Good afternoon. The CI team, can you see me? South Coast. I remember, Dr. You talked about the South Coast team. So it's an important time that we'd want to take you through very quickly. I see there is one thing, if you forget about everything, remember that human beings are never annoyed when they feel important. Everyone wants to be recognized. So it's never. So I'd welcome Ernest Some just to come and help me in doing this important exercise. So at this stage, you'd want to award on technical competencies. And on the technical competencies, the first thing that you'd want to look at is availability of information to make decisions. We all know that we've been talking about data, but the first step towards ensuring that we are able to have information to make those decisions is based on reporting. Do we all agree? So the first step is checking, do we have data or we don't have data? Then the next stage, we will be looking at ni data bora ama bora data. So the first stage, do we have the data? So we are going to look at the people who ensured that between 2019 and 2021, they have been reporting consistently and they have the highest reporting rates in the last 6 months. That is between April to September 2021. And so the second runners-up for vaccine reporting, you can imagine, these guys have worked so tirelessly. And in many times, they are never recognized, but you want to recognize them. So you can gaze. So this goes to who can guess the second runners-up? So I've said, someone is saying sabotage, it's coming. So the second runners-up, and we are going to, let me tell you the award that you're giving them. We are giving them a fund so that as they are meeting as a team, and sometimes when it is hot, someone is saying Mombasa. The second runners-up come from Mandera County, and this is Mandera West. Mandera West. So Mandera, can we get, they are going to be given their fund, and the representative is coming for Mandera West. So as they are preparing, the second team, you know, we tried as in supply to ensure that people are able to be motivated. I've told you, try this even at home. Recognize good performance and you will always see. So we thank you, Daktari. Pass our congratulatory message to Mandera West. Someone can assist him so that we are able to take that. Thank you so much. So we really recognize the team. The first runners-up, we'd want to encourage them to keep the tea warm, ensure that they warm everything, is Ruaraka sub-county from Nairobi. Ruaraka are having, as the team members are meeting, please ensure that they are able to warm, if it's water, tea, they have the kettle. So thank you for that. And the winners for this category, who are going with a very important thing, that over lunch hour, please encourage the team members. Thank you, Roraka team. Have a photo. Please clap for them. Thank you. The second team, over lunch hour, ensure that your food is warm. encourage the members to continue coming to the meetings and not be worried about cold food. And this is coming all the way from Trans Nzoia, and that is Endebess sub-county. Endebess sub-county. Daktari, just encourage the team members to continue reporting. Oh, so they can also warm tea. Thank you so much, Gali. Thank you. Daktari, continue. Thank you so much, Ernest, for that. I think I'll welcome Dr. Waiguru. Now, before you, Ernest, maybe just hold on. We want to have a special mention of an important team. They have been really consistent in ensuring that they are reporting on vaccines, and 5 out of 6 of the sub-counties of Mombasa have really consistently reported. That is Changamwe, Jomvu, Likoni, Kisauni, and Nyali. And we are giving them these whenever they're in their offices, they'll be able to see the nice looking. Some, please. The Mombasa team, South Coast team.
She can also hand over.
Okay. Okay, I've been asked that please come and also hand over. It's delegated so that you award. So you are able to look at, I believe the camera is able to see how these are very nice. So we have this prestige award for Changamwe. You are able to, who is, okay. So we have, again, for Jomvu, we have for Likoni. Oh, who is awarding? Okay, sorry. Oh, it's okay. And Nyali. So we really want to recognize that great work that they have done. So camera, please. Thank you so much. Now, we also want to award on reporting for family planning. And we are calling upon Dr. Waiguru. Please come and lead in this. And for this particular category, we'd want to recognize the following for the great work that they have done. So that we, thank you. So for the family planning reporting rate, we have the overall winner, that is, we've given Endebess. Is that Endebess? Yes. We want to recognize Endebess and give them a kettle. Family planning reporting, Endebess. Thank you so much. Endebess, as Endebess are coming. Thank you so much. Now, we'd want to continue to award in the same breath. And Sarah will confirm to you that previously we've awarded them, but we have to give an award for ensuring that we have absolute percentage difference. Like I've told you that this is one of those particular indicators that ensures that we not just have reporting. This separates between reporting, Bora, and Bora reporting. There are those people who report for the sake of it. So once, for you to make decisions with the data, you ask yourself, is the data of good quality? So for the absolute percentage difference, in the interest of time, please, on behalf of GAME, someone from Siaya County, this goes to GAME sub-county, and we'll give them, we'll ensure that they have a fan, so that during this, when it's hot, the team members at their meeting, Dr. Tindi, thank you for coming on behalf of GAME sub-county. The second, as And then I'll thank you for that. And then we'll be able to call upon that was the winner on the scale counties. And then on the data use counties, we'll want to give a microwave to who can guess? You know, microwave, I normally take time. So we are going to give this to Mukurweini sub-county. Mukurweini sub-county. On behalf of the team from Mukurweini, please. In Nyeri. Thank you so much. And thank you for that. Thank you, Dr. for helping us do that. In our characteristic, we normally ensure that the awards are given in the breaks. There are more awards coming. I'm coming now with the final awards. But before I come to the final awards, I'd want to welcome my colleague who will take us through a session. Dr. Johnson Anyona is taking us through the next session.
Sorry, I'm not Dr. Johnson Anyona, but I am Anyona. So we will do the panel discussion. We recognize it's lunchtime, sugars are low. We will do the panel discussion in the afternoon, allow us to set that up. But before we go on break, there are 2 counties that did not share their experiences with us. Yeah, so we want to recognize them. They are coming from the really hard to reach areas. You can imagine, if you see some of the photos of where they implement, a camel carrying the commodity, a CHV crossing some forests, we really want to hear from them. And I'd want someone from Mandera and Wajir to just share an experience of how they have implemented supply chain interventions in that area. And after they speak, they are the ones holding us from going to lunch. After that, we break for lunch and come back for the afternoon session. Please keep it brief. You are the timekeeper.
Good afternoon. So thank you so much. We didn't have time to do a PowerPoint presentation, but there was a gap in Wajir County, and InSupply came and filled in that gap. The people were there and they were ready. They took up the task. And as a result, we have had some tremendous achievements. One of them is that there was timely and coordinated impact meeting throughout the county and the sub-counties. Resupply of stocks to the healthcare facilities with shortages. The CHVs have really taken up the C stock and they've owned it up very well, improving on the reporting of the commodities. There was timely reporting using C-Stock again. C-Stock has improved accountability. There's monthly mentorship. There's community health assistance, and the community health volunteers have improved collection of reports. The CHVs have been trained and their capacity to handle commodities, report of these commodities and tracking of these commodities has improved over time. The challenges that we've experienced this time is that stock out of data tools with no budgetary allocation at the county level for printing the data tools, poor quality of community health data in KHIS, and frequent reshuffles of community health assistance. But I think what has really stood up is that the people have taken up the initiatives and their roles very well, and they've accepted that there's a gap and they filled in. Yes, thank you so much.
Thank you so much. That was Wajir County sharing their experience of what they have done, the challenges they faced. If you feel there's an intervention, a gap that we can fill in, please feel free to write it on those sticky notes. We will collect them and we will discuss them in the last session. Do we have someone from Mandera who would like to share? Let me move closer to you.
Okay, thank you. Good afternoon. I think much has been said, and the observation is across the board. What has been shared from the morning applies to all the counties. So there's no point of I repeating the same. It is only that we have not been given the opportunity to present, but also we could have had a lot of good practice that we could have shared. But all the same, what stands for us out clear from this implementation, it has come out that the way my sister just said, we are from hard to reach counties, and it has become possible that we can be able to implement this program for that matter in the nomadic setting, because the 3 sub-counties where we are implementing this program, it is in the nomadic and semi-nomadic communities. These are pastoral communities who have no specific area to stay, so you have to move with them, just from the lesson learned from the nomadic schools. So it is possible to implement this. And maybe now, maybe the only thing that is going to come out that's going to be a challenge, how we are going to track maybe at the end of the project. That is one thing that we are looking to. So the issue, the impact teams and all these things, it has become very possible. The counties have brought the issue of the child recruitment and all that. The CHVs are already within the communities. So supplying those stocks of those CHVs who are in the nomadic setting was something that stands for us out clear, that we can be able to cascade as we proceed in the years to come. Thank you.
Thank you so much, Adawa. I think you've heard from the hard to reach counties, it is possible to contextualize some of these approaches to different settings. So what works for Siaya may not work for Wajir, but we can help you contextualize it to work in your county. So thank you very much, counties, sub-counties, representatives, for all presentations, all your hard work. We recognize you, and we continue to hope that you can share your experience as we interact during lunch hour. And with that, I don't know if we have someone who can pray for us, then we break for lunch. Ngugi looks like he wants to pray for us, so over to you.
I think he's picked on me because both our names begin with a J. Let us stand up and pray, please. Almighty and ever-living God, we thank you, praise you, and worship you because of this sitting we have had. We thank you for all the deliberations we have had and the plans we have made. We continue to thank you and ask that you may establish those plans so they may come to pass. Now, as we go to take our meal, we pray that you shall bless it, that it shall be useful for our bodies. And indeed, those who do not have, oh Lord God, we pray that you shall provide for them. Please, we pray in your Son's name, our Lord Jesus Christ. Amen.
Thank you. You may break for lunch. And as you come from lunch, we will still be outside demonstrating some of these approaches. You may keep interacting with us. And please don't go away, because there are other awards in the afternoon. So your county, you as an individual may be recognized and you're not here. And recognizing that some of these awards are bulky, we will consider helping you to transport them. So don't worry about that. Thank you. Actually, we can't. We don't have. Where's lunch though? Okay, so lunch is served by the poolside. If you go up the stairs the way we came into the reception, there's an alley going like this, and then you turn to your right, you will see the stairs going down the pool, and lunch is around that area. I may not describe it correctly, but once you see the pool, know you're in the right direction. Let's be back at 2:00 sharp. If you come earlier, please interact with our solution tables and problem masters.
It always seems impossible until it's done. InSupply has adopted a new approach to improving competency within supply chain by developing virtual learning packages that help impact teams perform more effectively, what we call the IT learning packages. The learning packages are online-based courses designed to meet the needs of teams focused on promoting competency building. The Impact team is InSupply's signature approach of structured supply chain data use in problem solving and action planning. This approach helps health workers improve data quality and commodity availability through communication, coordination, and collaboration. It is a multidisciplinary quality improvement team comprised of 7 personas that enable the team to be operational, effective, and sustainable. These are Organizing Otto, Peter Problem Solver, Data with Diana, Supply Chain Sam, Influencing Irene, Resource Rita, and Lucy Leader. The learning packages have been developed for each of the personas, accessible free of charge online by the Impact team members using a smartphone, laptop, tablet, or a desktop computer. To learn more on how to navigate the learning packages, please check out our tutorial video for more details. Never stop learning, because life never stops teaching. By now you know about the learning packages course online. This video is going to take us through navigating the Impact Team portal. To access the portal, simply key in www.scdatause.org, that is www.scdatause.org on your browser, then press enter. To log into the portal, key in your username and password, which will be provided to you by InSupply Health. In case you forget your password, simply click on the Reset Password tab. Enter in the email used to register, then click Submit. An email with the reset detail will be sent to you in due time. Once on the home page, click the Learning Packages tab. The Learning Packages option will appear as shown. Next, select the learning packages you'll want to learn by simply clicking on the View Training button. Once you select the View Training button, this will direct you into the course. To begin learning, click on the Start Course tab as shown. Or need to go back to the previous section of your learning, use the scroll bar on the left as shown to move up or down. At the end of every learning package, you can access additional resources by simply clicking on the resource link provided of the resource you want. get certified and reinforce your knowledge further, click on the Get Certified tab, which will direct you to the Google quiz page. Once on the page, click on the respective course tab. This will direct you to the Google form. A certificate will be provided once you attain a score of at least 80% in your test. You may retake the quiz up to a maximum of 3 times. After completion, you will receive your results. It always seems impossible until it's done. Virtual learning packages that help impact teams perform more effectively, what we call the IT learning packages. The learning packages are online-based courses designed to meet the needs of teams focused on promoting competency building. The Impact team is InSupply's signature approach of structured supply chain data use in problem solving and action planning. This approach helps health workers improve data quality and commodity availability through communication, coordination, and collaboration. It is a multidisciplinary quality improvement team comprised of 7 personas that enable the team to be operational, effective, and sustainable. These are Organizing Otto, Peter Problem Solver, Data with Diana, Supply Chain Sam, Influencing Irene, Resource Rita, and Lucy Leader. The learning packages have been developed for each of the personas, accessible free of charge online by the Impact team members using a smartphone, laptop, tablet, or a desktop computer. To learn more on how to navigate the learning packages, please check out our tutorial video for more details. Never stop learning, because life never stops teaching. It always seems impossible until it's done. InSupply has adopted a new approach to improving competency within supply chain by developing virtual learning packages that help impact teams perform more effectively, what we call the IT learning packages. The learning packages are online-based courses designed to meet the needs of teams focused on promoting competency building. The Impact team is InSupply's signature approach of structured supply chain data use in problem solving and action planning. This approach helps health workers improve data quality and commodity availability through communication, coordination, and collaboration. It is a multidisciplinary quality improvement team comprised of 7 personas that enable the team to be operational, effective, and sustainable. These are Organizing Otto, Peter Problem Solver, Data with Diana, Supply Chain Sam, Influencing Irene, Resource Rita, and Lucy Leader.
Okay, settle down, please. We need to proceed. Those who are outside, please come in. We want to continue with the afternoon session. Is Dr. Masibo in the room? Thank you. Dr. Tindi? Dr. Tindi from Siaya? Is there? Yeah? Okay, please let him know that his session is next. All right, good afternoon. How was the lunch? On a scale of 1 to 10. 11? Any other? 10? Any other? Very good. I'm happy that we enjoy the lunch. Please let's settle down. We want to proceed. The left wing over there. The afternoon session has started, so please settle down.
Sir, the guy who Trans Nzoia, he didn't get the questions. He didn't get the
Jamani. Mtumie, si uko nazo? Mwambie aziangalie haraka haraka. Si ndio hizi? Okay, let's proceed, please. We are proceeding now. Please be quiet. Please be quiet. Good. So I hope you had a lovely lunch. My name is Johnson Anyona. I work for In Supply Health. In this project that we've been focusing on today for data use, I have been supporting Mombasa and Nairobi counties for the past 2 years. And it's really wonderful to see all this coming together and celebrating the success that we've had so far. So we're going to have a panel discussion in the afternoon, and you can see the stage is set for panelists. It's going to be an interesting topic of discussion that has been the recurring theme you've been hearing over and over again. Who can guess? The one thing that has been recurring over and over again, I think Dr. Alex mentioned it in the morning, that Yasmin has been pushing it down his head. Yes? Sustainability, exactly. So, in our day-to-day lives, I'd like to start by asking, by a show of hands, how many use the LED bulbs at their homes? LED bulbs. Ile inaandikanga energy saver. Those hiyo ndio LED. Now there are more hands. Very good. How many use pressure cookers at home when cooking, like meat and beans and hard things? And carrying your own water bottle, or if you're going to buy milk, you carry your own bottle of milk. Yes? Saving, right? Yes, saving. So that is the concept of sustainability. You're not only thinking about the here and now, but you're thinking of the future. Yeah? So sustainability is meeting your own demands without affecting the demands of the future. So whether it's reducing your carbon footprint or saving energy, for example, using the energy saver bulbs,
you're thinking about the future generations. So from a project standpoint, and we are here because of the data use and scale projects, sustainability is a complex aspect that needs to be unpacked. Yeah. And we've had some very wonderful ideas in the morning presentations on some areas that the teams have been trying to work out to achieve sustainability. And we really acknowledge the efforts, and you will see later on in the afternoon, we have some awards specifically on sustainability. So we acknowledge the efforts the counties are trying to put to have their impact teams and the interventions to be sustainable. We also are aware of the challenges that we are faced with at the county level. We know, for example, the issue of stockouts of commodities is a very thorny issue affecting the counties and the sub-counties. So earlier in the year, most of you remember we had cross-learning sessions. Do you remember the county cross-learning workshops that we had? And each county came together, discussed their best practices, their challenges, their lessons on the work that they've been doing. And at the end, the counties developed a sustainability plan. So the sustainability plans that were developed, each county had theirs, detailing the best practices that they had identified in that workshop. How are they going to make sure they live beyond the lifespan of the project? So that is going to be the discussion for this panel afternoon. We want to hear more and learn more from the specific counties on what or how they are going to make sure that the interventions we've implemented in their counties live beyond the project. So we are privileged to have with us this afternoon 5 distinguished panelists. And at this moment, I'm going to invite them to come to the stage. So we have Turkana panelist. As I call you, you can just walk up to the stage kindly. The panelists from Nairobi County, representing Nairobi County. The panelists from Mombasa. The panelists from Trans Nzoia. And finally, Siaya County. Please walk up to the podium for the panel session that we are going into next. Let's appreciate the panelists as they come. Ini yangu. Yes, so today I'll be Jeff Koinange. Tonight. All right, so I'll first begin by having a round of introductions for the panelists to introduce themselves. We'll start from my extreme right. You just state your name, your organization, and your designation.
Good afternoon. My name is Dr. Gilchrist Lokoel. I work for the county government of Turkana as the county director for medical services. Thank you.
Karibu Daktari.
Good afternoon.
Afternoon.
My name is Beatrice Bwabi from Nairobi County NMS, Quality Assurance.
Welcome.
Good afternoon, everybody. Dr. Mohammed Hanif, Department of Health Services, Mombasa County, County Pharmacist.
Karibu Doc.
Okay. Good afternoon. Dr. Tindi Felix, pharmacist, County Director of Health, Siaya. Thank you.
And finally, Dr. Masibo, the Director for Health for Trans Nzoia County and the Acting Medical Superintendent for Kitale County District Hospital.
Thank you, and a big welcome to our distinguished panelists. So this first question goes to Dr. Masibo. I would like to ask you, what does sustainability mean from your perspective?
I think every time we encounter that word, people tend to think about resources, about finances, which is, according to me, or in my opinion, just one of the facets of sustainability. I think sustainability is also about the attitudes, the work ethics, the processes, For example, in supply has been in our counties for a long time. Other than just investing financial resources, they have also capacity built the teams. And so there's a way they have been working. There's a process. There's a network in terms of how they do their work. And that also needs to be sustained. That's why some countries or some counties will be richer, but will perform poorer because the processes are not what they need to be. So even as we look to sustain in terms of resources, we also need to sustain in terms of what people have been taken through, what they understand those processes to mean, and how they can then pass over those work ethics and those processes to the next generation.
Thank you, Dr. Can we also hear from Dr. Tindi on your understanding of sustainability?
Yeah, in addition to what my counterpart has talked about, again, building up on the gains which already have been set, probably we get these gains in collaborations with different partners who have the same interest. You also get gains from other sectors who also plays a key role on probably the area which we need interventions. And when these particular gains have been put into perspective and into use in now in question, our counties and in respect to the Department of Health, how we sustain these gains using different processes, using different systems which have been put in place to ensure that the aspect, or in terms of financing and also in terms of equipping and in terms of capacity building on different areas, how do we ensure that the same system continues to produce the same output and even better output moving forward. So this can be from one particular, let me talk of one era to the next era, even with the change of different eras of management. The next era which comes into play to continue with the same, can they still continue implementing whatever the past era was doing? So that would be also another additional perspective. Thank you.
Thank you, gentlemen, from your perspectives at Siaya and Trans Nzoia. Okay, next question I would like to ask Bwabi. Nairobi County has been implementing the impact team approach for 2 years now. How do you think your county has integrated sustainability in the program design of impact teams? And if they haven't, do you have any suggestions on how they could have gone about integrating sustainability in the implementation?
Thank you very much, Anyona. Nairobi County, working together with the InSupply, has embraced the issue of sustainability in issues of impact team in 3 ways. One way that InSupply came in with was working with the existing structures, and the existing structures from the county, sub-county up to the facility level has paved way for the county to follow up through those channels to make sure that the gains that have already been achieved will continue to be there even after this program has come to an end. And this came through the learning packages that the members of the impact teams were well trained, and the technical support from the InSupply empowered them to reach out to all our facilities and all the structures in place to make sure that this program has been owned at the root, at the service delivery at the root. And so we are sure in the county that even after a long time, we'll be able to mentor others in the same program and continue to even recruit the new members who come to the county to do the learning packages so that they get enough knowledge and skills to continue with sustainability of the project. Number two is the integration of different programs. When In Supply came in, we were integrated together, the pharmacy, family planning, immunization, records, and even some other programs were also put in, like nutrition. And so this teamwork is something that the county is going to count on when it comes into terms of sustainability, because we are now working as a team. We are embracing each other's expertise to make sure that we achieve our goals. And we are sure that even after a long time, we will continue to maintain what we have already gained. Number three is about the technical support. In Supply came in with technical support, and the technical support was rolled down to the sub-county and even to the facilities. Now all the facilities in our county have been empowered, and they are able to meet every month and look at their data, identify the gaps, have a change package, and work towards improving on their gaps. This is something that is already inbuilt in the facilities, and this is the way to go. And last but not least, the appraisal of the indicators. When we are appraising the facilities for the flagship indicators, we would like to know how the facilities are doing and what actions they have come up with and how they have put in the strategies to mitigate the gaps. So this is already done, and facilities are making their targets, and they are following up to find out on how they'll be able to mitigate the gaps even at their level. This is one thing that has given us a lot of strength, and we are looking forward to see it grow even better after this. Thank you.
Thank you very much, Wabi. Very detailed explanation on how Nairobi County has integrated sustainability in the impact team approach. The next question I'd like to hear from the lake and the ocean. There's Lake Turkana over there and the Indian Ocean in the middle. Maybe we can start with Dr. Gilchrist. In Turkana County, In Supply Health has implemented a number of interventions, impact teams, C-stock, learning packages, potency, etc. So from all those interventions that we've been working on, what in your opinion has worked that you would like to continue, that you want to carry on and sustain beyond the project period?
Thank you very much, Dr. Nyona. You see, when you have, God blesses you with children, and then somebody comes and tells you which of the following children do you prefer, you see, you will be at pains to explain which one is your favorite, even if you know it exists. But C-stock has actually made a lot of impact in Turkana. This is a situation whereby, if you recall the earlier presenters who mentioned that the whole purpose of In Supply, previously JSI, was to ensure that how can these commodities reach the far-flung areas, hard-to-reach areas, while at the same time minimizing or reducing stockouts. So C-stock, in essence, has managed to build the capacity of those peripheral setups like Turkana, where we have 228 facilities. Of these 228 facilities, the ones that follow the main highway, they're actually very few. So a situation whereby you're having, timely reporting that is actually digital-based, and whereby we know at one point in time which facility is actually constrained with various commodities, and then we'll be able to take a corrective action at that point in time. It has actually made me comfortable because I can be able to serve the people of Turkana from wherever corners. Secondly, the impact teams, as they were, it has managed to create a consultative environment that is spanning from the community level up to the county level, where at any point in time, I am fully informed and fully aware of what exactly challenges exist in terms of commodity security and supplies. So by and large, the modules that also, the learning modules that were introduced, it managed to build the capacity of our people and be able to serve the citizenry and serve them better and faster. So by and large, yes, the in-supply, modules, the in-supply packages that have been brought to our county have actually played a big role, and we are happy.
Thank you. Let's hear from Dr. Hanif, please. What interventions have worked so that you wish to carry forward?
Thank you, Anyona, for that question. I think since we started, the impact model itself is a learning model for us. And bringing people together, different cadres, that actually exhibits the essence of multidisciplinary connection that needs to be there right from the county level up to the lowest level. So the impact teams have been able to, own the data. The sub-counties have been able to own the data that is generated by the facilities within those sub-counties. So there is ownership, and with impact teams, they have been able to improve in the reporting rates, and the quality of data has also improved. But with that, there's also that intentional need, to follow up where there is a challenge, where there is a problem. So, and that ownership actually makes one person from that impact team to be able to follow it up on an individual basis. It's not somebody will do it, it's not my responsibility, nothing like that. Members take it up and they make sure that there's a follow-up done, intentional follow-up, such that there's improvement in the reporting rate as well as the data quality that is generated. Thank you.
Thank you, Dr. Hanif. All right. Next question I'd like to hear from Dr. Masibo. What do you think is the role of the county government on implementation of sustainability?
The county governments have, health is about the counties. Actually, they are the owners of health. So first and foremost, that is their mandate. But in terms of sustainability, especially of the activities around impact, I think we have a role in terms of even the coordination. A lot of the coordination has been done by in-supply hitherto. So it's important for the county now to start looking at how can we coordinate all the teams to continue doing the work they have been doing. We also need to look at leadership in terms of the very highest offices, in terms of the CEC, in terms of the chief officers and probably the directors, just getting involved and getting to know what is happening around in terms of impact teams. This morning, I think I was very, very impressed by the indicator tracking tool. And it's a tool that can be scaled up to even the highest management level. It's very simple for even the highest manager to understand. So I think that is one of the things we should also look towards doing. Of course, recognition. I think, I don't know about the other counties, but for Trans Nzoia, I think we have lagged behind. All the recognition that has happened up to now in terms of impact teams has been done by in-supply. And that is one of the areas we need to look at. And it doesn't need to be very resource intensive. For example, when we are looking at competitive promotions, we can just say whoever has done the learning packages, it can be considered as one of the added advantages. So simple things that we can look at in terms of just motivating people to continue doing the work they're doing. The other area could be probably just creating awareness and recognizing the best performance as we have done today. I'm sure the counties that we are here today, the sub-counties that have been recognized, will be feeling motivated. And if we sustain that, then the work that has been going on will likely continue. I think in a nutshell, that is what I would say.
Thank you very much, Dr. Masibo. I think I'd like to hear now on the next question from Dr. Tindi, and also Hanif, you can chime in. Who are the key stakeholders that you have identified in your journey of sustainability in your respective counties?
Thank you, Anyon. Stakeholders cuts across, and even as we look at the Department of Health, you'll realize that this is a department which greatly depends on collaboration to make headway in most of the interventions. And in regard to the budgets and the funding which comes across in this department, allocation towards the department is not, probably we can talk of not sufficient to carry out all the activities which are related to intervene in areas regarding health. And stakeholders are very key. And I would say that it starts with the reorganization within the department. And I'm talking about reorganization within the department because we do appreciate that we have a strength that in county government and also in government sectors, there's systems which are already in place. These systems just requires a lot to be done around system strengthening, so that different issues which needs to be tackled, which probably are weak, when they're strengthened, we can produce the maximum out of it. I've gone that way just to say or to bring across to the members that system strengthening within the department is very key. And when we start within ourselves, being the key stakeholder in all this, that will play a major role. Then now we can now look outwards and now look at other collaborators in terms of stakeholders. We have other government institutions within the county government, the other departments who are also key in the journey towards sustainability. You'll realize probably in regards to aspect of now technology, information and ICT, that is, probably we'll have to collaborate with other departments to bring in that expertise into the department to solve some of the issues which we cannot solve as a department. So other departments play a key role, and they are stakeholders in the same. We also have a strong stakeholder in the national government as a key player in issues related to sustainability, because we'll always be looking at the national government in issues related to policies moving forward, and that is very important to the sustainability process. And yeah, just to bring across that, I mentioned ICT and also the finance department. All those departments are very key around playing key stakeholders in this. And moving forward, we have other collaborators and partners who probably are not non-governmental, which we work with constantly. And I started by saying that health demands a lot of resources. And the non-governmental partners will always bring in that additional input across board, not only finance, but also other areas in relation to capacity building, which is very important. And just to finish on this, the community, again, the community we are working with, who ultimately these services get to, plays a major role as stakeholders. And one way or the other, when we get their input in relation to what are some of the things which as a department we've been able to give them, which probably they feel we can do differently. They play a major key in giving that information so that we can change probably the approaches which we have been using to reach out to them. Thank you.
Thank you. Dr. Hanif, anything to add to that list?
Dr. has taken all the limelight, man. He has exhausted all the points. But just an addition, I think the facility in charges, they play a major role because they are the ones who are the supervisors of that facility, and they're the ones who generate the data that comes to us. Yeah, and they are the ultimate implementers of the policies and the guidelines that are formulated at the national level. So the facilities play a very big role, the facility in charges especially, yeah, and the sub-county teams and the county teams because of their oversight role that they play. Yeah, so they become important stakeholders within the stakeholding, you know, they are the stakeholders. Yeah, we cannot forget them. I think Dr. also forgot to mention probably the County Assembly Health Committee that plays a very big role. Yeah, as Samburu County highlighted, you know, they had to take them out and, you know, to Nakuru, and they managed to get 50M out of them. You know, you have to have the health committee of the county assembly very close to the department. Failure to that, we are doomed. Yeah, we have to have that political, you know, arm next to us. Very important stakeholders, because they are the ones who will push, you know, the finance, the budget of the health department to be approved. Yeah, the way it is. Yeah, so we have to have them close to us for any projects to be sustainable and successful.
Thank you, Hanif, for those additions. The next question goes to Madam Wabi. You had mentioned about how Nairobi County had integrated sustainability riding on existing structures. Going forward, how do you monitor aspects of implementation to ensure that they're institutionalized? How are you planning to monitor?
Thank you very much, Dr. Nyona. Nairobi County is working on a partnership with the facilities. Facilities are like implementers. They are our eyes on the ground when it comes to service delivery. And so through the in-supply, we had that ITT, indicator tracking tool, which was mainly working through the DHIS. And the data that we were receiving for analysis was mainly retrieved from the DHIS. And so with Nairobi County is going an extra mile to have our facilities, all our facilities upgraded to EMR, whereby we will have accurate data, complete data, and data that can be retrieved at any time and can be analyzed, and gaps can be identified. So through this EMR, Nairobi County will be able to even follow up and see how the facilities are performing, how the indicators that matter in the county are performing, and in case there is any indicator that is not doing well, then there is that partnership of working together through support supervision, through OJTs, through capacity building, to make sure that these indicators have gone up. That is one way which Nairobi County will work through to ensure that there is evidence decisions which are made from the facilities in terms of giving quality service delivery to their customers. Number two, Nairobi County will also be using the appraisal form. All our facilities are appraised and they have targets on which they work against. So every facility has their targets, and at the end of mid-year, they are supposed to appraise themselves and see how much they have performed. So the county is able to follow up and see which facility has not done well through their appraisal. And this will also help the county to monitor whether the facilities are working towards the progress of improving the indicators or not. Number 3 is about resource. The county is working in collaboration with other stakeholders and also the service providers to make sure that there is consistency of supplies and also commodities. Because sometimes you can be having the people to work, you have the data, but you don't have the resources. And so you will find that there are some services that are not being offered. So Nairobi County is also working in partnership with other partners to make sure that there is consistent supply of commodities, and not just consistent supply, that the commodities are well managed to make sure that there is an impact in the service delivery. And the last but not least is about the community aspect. Nairobi County has gone ahead to recognize the work of the CHVs. And this is an aspect that is going to help the county to make sure that at the household, there is service delivery and there is ownership of health. And we know when there is ownership of health at the household, then this makes health even easier. And so sustainability will not just be at the facility or the sub-county. It is coming from the household. And the CHVs have been motivated. The county now recognizes their work, and they're going to be given a stipend for what they are doing. And this puts Nairobi ahead in the service delivery.
Thank you. Thank you very much, Bwabi. The next question I'd like to hear from Dr. Gilchrist. I think the focus for today is how implementing partner projects are able to be sustainable. But I would like to hear from you in your perspective. Do you think government-initiated projects also need to have sustainability? And in what way?
Absolutely. If you look keenly at the way government does its operations, and I will narrow down to the county government, it does so through what we call county development plans. These are 5-year plans that are actually packed and broken down in annual work plans. So the annual work plans incrementally feed into CIDP. If you again look at even the way it disburses its resources, it does so through what we call program-based budgeting, which is usually an extrapolation of 3 years of funding from this year. Then the next year, it feeds whatever you contributed this year, feed into next year and the other year. All this, in a broader perspective, it is feeding into Kenya policy framework, it's feeding into Vision 2030 and the social pillar. So government actually has all these plans that are ingrained on the sustainability that we are talking about. So it looks at the bigger plans, breaks it down into midterm plans, into annual work plans, and then into quarterly implementation plans. So that is how government looks at sustainability in that mantra.
Do you have Ken? Ken, I had a question for you also. Very good. So Ken was supposed to be one of the panelists, but it's I also give you this chance to answer this question from the implementing partners perspective. What do you think is the role of in-supply health as a partner on exit in ensuring the gains are sustainable?
When they were speaking, actually they have highlighted almost everything that in-supply has put in place to ensure that life moves on beyond in-supply. I'll start with a practical example. Maybe some of you may not know, we were in Siaya, for example, through the support of Grand Canada's Challenges Canada, and we did our last meeting in July. And when they were presenting data, you were able to see they presented data up to October, meaning they have been living even without us. I think I just to give one highlight, but I'd want to highlight the following specifics that the way she highlighted, one, we integrate within the existing systems. I think that is one thing. We always begin with sustainability in mind. We don't wait when it's 3 months towards the end or few months. I think that is very key. So we begin with sustainability in mind, integrating within the existing system, working with both county governments and national governments, that whatever we begin does not end with us. So just to demonstrate as part of that, like system, for example, we've ensured that we've integrated with KHIS. KHIS is living beyond us. And the fact that people are able to access that data to aid in that is one great stride that has been able to implement. Number two, we don't also, allow me to use this joke, we don't begin what we know can't be sustained. So we are not in some instances, especially at the beginning, we are never, some people may not, are not used to the way we do things. Like we don't provide kids and snacks for you to eat. And the motivation of eating is not from kids and snacks. Yeah? So we don't start to bring in something that when we go, now people will start missing it. Yet we will not be able to provide it. So we try to, how do you have your meetings? So we provide the one. We look at systems that can work beyond. We don't provide, for example, we don't provide, for example, phone. So we use what the CHVs have. We provide this with the human-centered design. We look at what do you have and work with what you have. The solutions that we have, for example, if you have a feature phone, it will work for you. If you have a smartphone, it will work for you. If you don't have a phone and you're a CHV, we still make sure that you are able to, your job can still continue. If you are in a place where there is no internet, we are able to factor in what is there. So we co-create with the teams. I think all of you know that we believe not that we don't identify the leadership, but we believe in multidisciplinary approach. So that's why the impact teams have got different people coming together so that we are able to have what we call a common goal, a common vision. It's everyone's business and be able to identify the different strengths and we believe in leadership, the traditional and the non-traditional. There are people all of you that I may not be the director, I may be the MOH, but if you want this thing to pass through and through the other person, it will happen. So we try some of those things that happen. We also left things behind that can go beyond us. Like the ICT, we've made sure that it's on a free and open system, something that is free. So no one would want who will be asking for you to pay to use the ITT. The ITT is as live as the data in KHIS is available. There is none of us who works remotely to ensure that now we want to now refresh the data. Like we put it that it's an automated system that can be able to work in that particular environment. We believe in capacity building, so TOTs. So wherever we work, we believe we don't come and train the kids. Let me use that example. And lay that as the county, the CHMT train the CHVs. So we start by doing what we call a cascaded approach of capacity building. So we have TOTs at county level, we have TOTs at sub-county level, and we have the chance who then finally trains the CHVs. So we believe if you adapt such a process of a cascaded approach of ensuring that you train the people. And of course, they've mentioned the learning packages, something that you can learn on your own, even as you are going. We are not asking for any fee. I think I've mentioned so many. Thank you again. So I've mentioned so many. Working with the national, so that when we are talking about systems to sustain for supply chain, Do we have, for example, updated curriculum that can work in different settings? How do we work with the government to ensure that the policies are put in place, so that the system that we have just put in place is not just what in supply is. We are not in the business, I always say, we are not in the business of making, and we are lucky to have worked with different, whom we call clients or donors, who understand that we can run and say we have failed. We admit failures. We admit that it's not working. That's why in the second phase, we realize that the actual implementing impact teams is best placed at sub-counties rather than counties. So we are able to learn and say that this may not work so well, and we're able to work with each and every one of you. So I think the greatest thing is we also believe in partnerships, partnering with national, county, other partners, so that when we are leaving, other partners are able to say that this is a good thing that you can continue to work with us. I think I would have added much more and more, but in the interest of time, thank you very much.
Thank you very much, Ken, for the in-supply perspective on sustainability, starting from the beginning. I think those are the questions I had for the panelists. I'm told we have some questions coming in from the virtual directed to the panelists. So I'll ask George to read them out, and then any panelists can respond to them.
Thank you very much, Johnson. So first, we don't have questions yet, but we have additions and probably points that the teams are sharing. So I'll just read them. On the first questions that you mentioned about sustainability. So Vincent from Transoya says that my definition for sustainability is maintaining the gains and structures put in place from one system to the next. Then there's another comment from Ruben of Turkana. He says, sustainability is a way of meeting our own needs without compromising the ability of future generations to meet their own needs, whereby we ensure we put in place all the requirements needed to improve health services in our communities that will be helpful in coming generations, like stock out of commodities. We come up with strategies to be used to ensure no more stock out of commodities. So that is a comment from Turkana. So we've not yet received any questions from the live stream. So we'll request more comments to come either from the floor. So is there any question or comment from the floor of the House? Yes, Dr. Mungai. Thank you.
I think it's planning sessions. Interested in HIV related commodity usage and uptake, the variation, the loss to follow-ups, and And they're actually beginning to realize that they can ride on stock as well. So that will also help build the sustainability, because there'll be some buying there as well. Then also, not to forget, I think my colleagues in the panelists had mentioned it, the county government. They can also, if they see what we are doing and we get that buy-in from them, but most of this, the executive, they're politicians. So you have to package it in a way they can understand that they can gain. And for us in Samburu, we are showing them that commodity security for our clients, and that's what they want. Especially being a political year, they will even listen to you more before January or February. So I think that's what I can add. Maybe my colleague Rotich from Samburu can add something.
Just for the monitoring part, and we know we've been able to have the learning session, which was led by the government. We are able to do that in terms of monitoring the activities that was supported by CISTOC. We also have the review meetings of the sub-counties that helps us to look at how much we are doing in terms of the CISTOC activities. And there is also another opportunity in monitoring through support supervision, which has been said and canvassed. And the last one is what I was calling, I was saying this one to CISTOC, what they had in terms of facilitating sustainability. They had an exit plan. The exit plan was well. We were able to meet, we plan with them, we discuss how to sustain. So I think that is what I can add. Thank you.
Thank you, Rotich and Turkana County.
Yes, thank you. Thank you very much for those great additions to this topic of discussion on sustainability. Do we have any questions that are from the parking lot? All right.
So the question goes to the panel, something about facility in charges. And I think it was the panelist from Mombasa. So the question is, how can we support facility in charges to balance with the conflicting responsibilities and roles at facility level in supporting community health strategy? Do I repeat the question? So the question is, how can we support the facility in charges to balance with the conflicting responsibilities and roles at facility level in supporting the community health strategy?
From my perspective, I think facility in charges are the best placed at the community level, because they are the ones who are within the lowest level, the level 2s and the level 3s. And they are the ones who sit in those facility management committees where they interact with the community, and the committees are the representatives of the community. So when they are negotiating, there's that interaction, and there is the explanation of what is happening within the facility. So the CHUs, even the CHAS, the community health assistants, are based at that facility level. So the facility in charge, being the overall manager of that facility, they are the ones who will be able to interact with the CHAS, who are the link with the community and the CHVs. So that way, the facility in charges take up that role to be able to kind of be the oversight of the community activities, and they have that kind of one-to-one with the community leaders as well. So as much as they're doing their role, being the facility in charge, they can also be meeting the demands that come from the community. I think that's how it can be.
Yeah, anything to add, Dr. Masibo?
Yeah, I want to agree with Dr. Ari on what he's just said. I was actually going to say the same thing. I want to also say that it's not true that it's a conflicting role. Actually, the roles are complementary. The future of healthcare in Kenya or in the world is going to be private, primary healthcare. And facility in charges, as is rightly put it, are supposed to prevent things from going from preventive to curative. They have a role, a very big role. Some of the things he said, the facility, the community health units are actually linked to a facility. The facility in charge is actually the secretary to the health facility committees. So the two roles should actually be complementary rather than conflicting. And I think we need to find a way of the facility driving the primary health agenda so that it doesn't always deal with curative issues only. So from where I sit, I think it is very, very complementary and not at all conflicting.
Thank you. Thank you very much. Great question from the virtual participants. I think I'd like for us to close it at that point. Please, a big round of applause to appreciate our panelists. You are at liberty to take back your seats. Thank you very much, ladies and gentlemen. And for the rest of the participants, thank you for your audience. I think this has been a very great and rich discussion. The theme here is sustainability, and we've had very great points on how we can move forward with some of these interventions that we've implemented and ensure they live beyond our project period. I can see people are tired, so I'm going to ask everyone to stand up, please. Please stand up as we close this panel session. Mwanakarama, stand up. Sasa, hold your waist akimbo. I want us to spell the word sustainability. Yote. Capital letters, not small, eh? So on my cue, you will do as I do. So S, U, S, T, A, I, it's capital I, yeah? N, A, B, B for boy, I, L, Maure, I'm seeing you, L, I, T, you're almost there, Y. Thank you. Back to Judy. Okay. All right. I've been made aware that there are some very active people in our Twitter handle, and just to encourage them that we are seeing you and keep doing what you're doing. Dennis Sinei has been tweeting furiously, so very good job. We are trending. Jessica Atieno, keep tweeting, please. The hashtag is? Where is Florence? In supply health. Huh? What's our hashtag, Florence? Yes? In supply DU 2021. So make sure you put that hashtag when you're retweeting. Ernest Some also doing a fantastic job on the Twitter. And of course, panelist, Dr. Hanif Jean. Good job. Keep tweeting to the rest of us. Let's make this event trend. Santeni, back to Judy.
Thank you, Johnson, for the panel discussion that has been very good, very engaging. We have learned a lot, and we are hoping that we should be able to sustain the gains that we have made so far as data use is concerned. Now, I think this is the best time for us to go back to the counties and recognize those teams within the counties that have been able to continue to hold their impact team meetings without a lot of dependency on the in-supply teams. They have been able to hold their meetings even without support or with very little support from the in-supply teams. As you are aware, the in-supply teams have been supporting, giving TA to all impact teams in all the counties. And they have been able to observe over time which are those teams that are able to conduct their meetings, hold their meetings without a lot of support. And we, as they were looking at, they were trying to identify those teams, they looked at a number of areas. One area was those teams that are able to conduct impact team meetings with good quorum consistently. That's one of the areas that we looked into. The other area is the ability of those teams to extract and visualize data for their teams to review and interpret. So they were able to extract data, visualize it, so that their teams can review and make sense out of that data. The other area that we look at is the area of able to convene meetings with no financial assistance, and creatively be able to implement their action plans. So these are some of the areas that we looked at. For the teams within each county, we were able to pick at least one team. We know all teams did a good job, but we were able to pick at least a team per county that was able to meet our criteria and be able to conduct their meetings with very little dependence. In other words, they are becoming self-dependent. Before I start awarding the teams, may I request Dr. Macharia, please, to come and help us recognize and reward these teams who have done a very good job so far. These seats could be moved from here so that Dr. Macharia can have enough space to breathe. Karibu Daktari. Yeah, so I will call upon the teams, and and these are sub-county teams, as we are all aware. They are all sub-county teams, and we are hoping that the sub-counties are here. If they are not here, then the county representative can come and receive the gift or the award for them. Mandera County, the impact team that has been able to who has been able to meet without a lot of dependence on the national or the in-supply team is Banisa Impact Team. Banisa, are you here? Please clap for them. They have done a good job. They have done a very good job. Who is coming to receive the award for Banisa? Banisa, is that how you pronounce it? Good, Banisa. Make sure this one, when you go, it goes to the county, it's put somewhere where it can be seen, so that we know you guys have been doing a good job. Dr. Mashari, I don't know if there's anything written on that.
Yeah. Yeah, thank you. Banisa, is it Banisa team? They have won the trophy, Best Supply Chain Impact Team in Mandela, awarded by In Supply Health.
Okay. We can take pictures, please. Thank you very much, Vanessa. And as you go, please clap for this gentleman. I hope you come from that county. From Nairobi, we have Ruaraka Roysambu. That's the team that did marvelous. Ruaraka Roysambu, you can come. I see Nairobi one likes coming, many of them. Please, you're welcome. You can come and receive all of you on behalf of your county. Yes, please. Thank you. The Nairobi is not gender sensitive. Thank you very much. Clap for them. Thank you. Take a picture. They want to be documented properly. Yes. Thank you, Team NMS. They're called Team NMS. From Nyeri, we have Mukurweini sub-county. Please come and receive your award. You are from Mukurweini yourself, it looks like. Yeah, because there are many.
There are other people from Mukurweini.
Okay, Nyeri County. Just hold on, a good photo is coming before you go. Thank you very much, Mukurweini. And the Nyeri team at large. Nelly, I see you. You are doing a good job. Thank you very much. From Samburu County, we have Samburu Central Impact Team. I think there's a sub-county by that name. Yeah. They're doing very well. Encourage them. They should continue like that. And even those other sub-counties have not been mentioned, let them also do the same. Thank you so very much. From Siaya, we have a county called Bondo. I think Bondo is where Raila comes from. Please come and receive your award. You have done well. I hope that. Karibu sana. Yeah. Thank you very much. Thank you so very much. We move to Trans Nzoia. Trans Nzoia, I think there's one sub-county that is featuring too much. Endebess. Endebess from Trans Nzoia. Asante sana, hongera. Thank you, Dr. Masibo. We are moving to Turkana. Turkana, we have Loima. We were told it borders Uganda. Loima sub-county. Thank you very much. And finally, we have Wajir. Wajir, we have Wajir North IT team. Wajir North. Yes. No. Wait, before you request. Before we request, we have our team from 001. We are not forgetting you. Mombasa, we have Mvita IT team. Karibu sana. Mvita. Doing very well. I can see they're also behaving like Nairobi. They're the second city, I think, in Kenya. So they must try to look like Nairobi. Karibu sana. Thank you very much. It's a big team. Karibu sana. And that's how you win as a team. Very good. Thank you. Thank you very much. Thank you so much. Somebody had a question.
When we were taking the picture, photo, they had only projected for Raka, so there was no mention of the photo.
Now, is it there now? Take it again. Then you are safe that way. Hi, okay, the Mokrowen team, you can quickly come. Madam, come. Because Ngoge has said this. Dr. Ngoge, you happen to have, that's why you had the guts to talk to me like that, because you know me from long time ago. Okay, Mokrowen, thank you very much. Asante sana. Thank you. And thank you all for this. Please encourage your other sub-counties to continue having the meetings. Asante sana. I think I want to hand it over to Judith. Hello. Yeah, thank you. Nipigie makofi nikienda hata mimi. There are not many people who are my age who are here. Thank you very much.
Thank you so much, Amos and Dr. Macharia, for that. So those awards are for specific impact teams. Yeah. So you know that sub-county that has been mentioned, Ruaraka, Roysambu, tafadhali Dr. Maore. Tukikuja Ruaraka, tupate hiyo kikombe huko for this year. And then next year it can go to someone else. Yes, it can rotate. That's the intention of those trophies, that they rotate. As you recognize people improving, let's recognize them with that trophy. Isikae kwa one sub-county, let others have the opportunity to win as well. Okay, we are almost at the tail end of the workshop today. We want to go to the point where you remember those sticky notes that you're writing for us in terms of what are the gaps, what are the opportunities that we can use to enhance. We've not had a lot of interactions in terms of questions and answers, but I think what you have given us in terms of the sticky notes, we put them together as what gaps are there, what opportunities are there, and what's the way forward. What's our key takeaway as we wrap up this meeting today? So Laura is going to take us through that. After she does that, there's one more award that we will need to recognize, and then we will call it a day. Sawa, so don't lose hope. We are almost done. And I'm sure you're waiting for that last award. It may come to you. Sindio? Yeah, I'm told there's a microwave to go. So it's coming up. It's coming up. So let's just see what ideas have come up. And if there are any additions, we'll give an opportunity for people to also share additions. Laura?
Judy, thank you. I've already made friends around the counties, especially those with kettles and microwaves. Chai na chakula will be eating together. Congratulations, well done. It's been a long journey to get here. Someone said, start with an exit plan. I had a comment from this side of the room. Every project should start with an exit plan. And we hope that as in supply, that is something we're going to take up even to the rest of our partners. As we start projects, what's the exit plan? Are we building on KHIS? Is the ITT working independently? Are impact teams something we can actually use? I absolutely like what has been done in Samburu, where it's already in the budget. I know Turkana was looking for how to put this in the budget. Where is Dalmas? How to put the CHB allowances. It can be done, okay? And let's keep motivating them. We did a lot of sticky notes in the morning, and some ideas are coming up as questions, comments, even as we had tea and lunch. We have put them all here. Again, as in supply, co-creating. We want to create together, because when we create together, then we own it, we sustain it, and we move in whichever county we are coming from. All right, so what future opportunities do we have? I'll start with key takeaways. We've already said this one. Ama? Yeah? It is great the way CHVs are motivated in Samburu, Varo, and cold chain. Someone talks to data, someone talks to himself, data talks to him. Wasn't that a good takeaway from one of the presenters that we had? All right. In Nairobi County, CHV is already receiving a stipend. How did that happen? And I'm looking to Beatrice. Those best practices are the ones we'd like to hear, because then we can go and incorporate them in our counties and in our political arms, because we know that we work as one team, as Amos has rightly said right here. And then there'll be improved service delivery, which is happening. Someone else in the panel here said primary healthcare is the core of what future healthcare is going to be. So if primary health is strong through our CHVs, then we are going to make it. All right, here are some other takeaways. And from here, I'm going to be pausing for a bit. Our sticky notes are still on the table. We have in-supply team members all around the room. We can pick them up and still put them up as we talk about it. So these are from the various sticky notes that we have. I'll start at the bottom. Start with the end in mind. Yeah, CSTOC has been incorporated into KHIS. So in-supply came in with an exit strategy 3 years ago. And here we are incorporating things. Thank you, Ken, for that one, starting with the end in mind. We need to align our interventions with the community health strategy. We need to run as one, not in parallel or antagonizing. We improve on it and see how to make it even better. How can we sustain innovations introduced by MOH and the partners? That sustainability we've talked about over and over. That's what the panel discussion was about. Supply chains focus on stock out rates, but to build a strong supply chain, we must invest in processes and people. How does it work? Without the people, we say no commodity, no program. And no people, no process, then we know how that goes. Samburu, again, another thumbs up for what has been done in Samburu. Best practice. People are going to be getting stipend from December. So we'll join Beatrice in Nairobi to say our CHVs are receiving something, isn't it? So Dr. Mgaya, asanteni sana. We had some questions. And here it's going to be, can I say a quick fire one? As we can see, Wajir, what strategy was used to encourage uptake of learning packages? Wajir got an award for that and people are curious. How did we get that happening? Do you have anyone from Wajir who can give us a quick answer? I'm looking at the table here. Where are our microphones? Any mics? Asante.
Thank you. What has encouraged Wajir is self-directed. You know, people have the, you know, that ambition to do the work. The other thing was teamwork. There was a lot of team playing in Wajir County.
I'm motivated to do it myself anyway. So myself, I've got there and teamwork. So everyone pulling the other up to ensure that we got them an award. What could have contributed to the high levels of hot alarms in the beginning?
When you say in the beginning, initially.
Does the chart?
Yes.
How are commodities for CHVs ordered and are they budgeted separately? Samburu and Siaya.
Yes, thank you for that question. For the commodities for Samburu, we order through KEMSA and MEDS. There's nothing out of the ordinary. It's not special. We just know that the facilities, we do the catchment, we know the catchment population. We understand the mobilities in that population and the consumption data. So it's just part of the normal order request. But now we factor now
that there'll be increased access of health to the communities. So we are actually bump up the quantities to cater for the increased access through the CHV engagement to the communities. So it's just part of the normal ordering process with a few tweaks here and there to factor in the uniqueness. And also we also look at the season. There is a dry season, there are different illnesses. If it's rainy season, there are different sets of illnesses and factors like that. But it's just part of the normal ordering process.
Is it data-driven decision-making? Because you're factoring in everything else. That's really good. Thank you, Team Samburu. Team Siaya.
Can't see very well. What was the motivation for reporting of the CHVs? As I said in the presentation, we had a section of CHVs that were actively implementing ICCM at the community level, with incorporation of CSTOC and every CHV being able to report what they have, what they don't have. Other CHVs also took it up because they felt when you report, you'll get commodities. If you don't report, you won't get commodities. So it was a good motivator at the end of the day that reporting well on a platform that was visible to all aspects of management from the facility up to the county was a good way for them to actually continue reporting on a regular basis. That was the biggest motivator. Then the feedback to the county government was that avail commodities at the community level, the person at the lowest level will be able to get a service without having to visit the facility, without any cost, and also minimizing on deaths that are common at some point in time when there's no care available. Then for the last one, it was actually a Lego Songa, the colors. I think the person who was asking the question maybe was colorblind, men generally. So the other one was light blue, but it was a Lego Songa. It's a very good question, but as I said, one of the challenges, one of the issues was that the impact teams at sub-county, there are some sub-counties that took it up very well, and there are some sub-counties that did not take it up very well. So in that specific sub-county, you find that the receipts, because they also have the highest number of CHVs in the county, they have 517 out of the 2,000. So they have like a quarter of the CHVs are in one sub-county. So there was also a change of leadership, a change of staff. That kind of staff turnover is also affecting, and also the immediate supervisors. We had also new chairs that were employed, who are also deployed to that service delivery level. So currently is when they are being trained on aspects of ICCM. So that capacity building aspect was also another aspect that we could not do active follow-up, considering the large number of CHVs that they were handling at that time. But going forward, through the leadership of the county, we're expecting that there will be an improvement so that it becomes across board for everyone to be able to get commodities. Thank you.
All right, still with the mic. One thing that I've heard is that you sold to the county that if we get this product, there's going to be less burden on health facilities, less visits, so lower costs. So that is already something we can already do in our respective counties. If this happens, then this will happen. Let's invest now for preventative as compared to, curative that costs. I want to take us back to question 3, please, which was Samburu and Siaya. How are commodities for CHVs ordered, and are they budgeted for separately in Siaya?
Thank you. I'll just respond as per my counterpart from Samburu, because that is what we are also doing in Siaya. For commodities which trickles down to the CHVs is commodities which have been ordered for the link facility, but now there is that aspect of ensuring that community unit attached to that facility also is able to get a portion of this commodity which has come to the facility. So it follows the same channel, and these are basically the program commodities. Some of the commodities which are not under the program like the zinc and ORS, are the ones which are under the county budget, which also get to reach to the community level. And also when we are budgeting, we budget for the facility, but taking into consideration the community unit attached. Thank you.
Okay, those are very good ideas, and we can always note them down to see how can we do this? Are we doing it already? How can we strengthen it? The next slide is, I think, directed only exclusively to Team Turkana. So I'm looking around the room at our Turkana teams. Turkana, do you have reporting timelines? Which commodities are the CHVs distributing? Who procured the CHV funds? How are the CHVs motivated? Are the CHVs given a salary or stipend? Are there plans to scale up C-stock to other sub-counties? Those are a lot. So just from the presentation that you did, there was quite a bit and a lot of interest generated because Turkana and Loima is piloting hybrid paper to digital. So probably take us through just one line per each of these bullet points.
Thank you so much, Flora. Starting from the first one, do you have reporting timelines? Yes, we have reporting timelines. CHV should make sure that they report on 28th of every month. That is a timeline. And then at the facility, the report should reach the sub-county HRIO by 5th. That is like cross-cutting. We have timelines. And then B, which commodities are CHV distributing? We have a lot of commodities that CHVs are distributing, especially the ICCM commodities, beginning with the antimalarials, that is AL. With AL, we have also the RDTs, the testing for malaria. CHVs are testing for malaria in Loima. They also have Paracet tablets, although we don't have the disposable one, but we are using the tablets, the junior one. And we also have the antidiarrheals, that is zinc ORS, for prevention of diarrhea. So CHVs are distributing and they are managing diarrhea at the village level. We also have management for malnutrition because Loima is still a pilot for ICCM plus CIMAM. So we are doing that. We are still waiting for approval because we already completed the research. So the CHVs are still continuing with the distribution of nutrition commodities. That is the RUTF and RUCF. And then we also have additional of dewormers. CHVs are distributed at the community level. We also have the water purifiers. CHVs have, and some CHVs have tetracyclines, ointments at the community level. We also have like male condoms. CHVs are being given to distribute at the community level. Sometimes we had sickle beads where we give the CHVs and they do it very well among other commodities. C, who procure the CHVs funds? It's courtesy of in-supply help, though it's like the CHVs themselves procure their forms using their allowances during the trainings. So it's their own funds, they're not for in-supply. So it is through their training that they were supposed to get the allowances, then they did forego their allowances to have the future phones for them to own the phone and use them to report. And then the D one is, how are the CHVs motivated? CHVs are being motivated through many ways because of
for them to like do saving and loaning. Not all of them, but a few of them. So that's how we motivate them. During the trainings and during the meetings, we do give them allowances because of the distances that they're coming from. I said this, a CHV can come from like 40 kilometers away from the facility, and we don't have public transport. So we give them like to give, to have the CHS Act, Turkana County, I think around 2019. So the CHVs in Turkana County, they are getting a stipend of 3,000 per month. So we are among the first counties to have that act in place, and it's working now. There are plans to scale up CSTOC to all sub-counties. Yes, that's our prayer. We will work together because the TOTs are there, the county TOTs, sub-county TOTs. We also have the CHAS as TOTs. So this is easily to be scaled up. Working with the county government, we are able to do that in partnership with other partners like Save the Children. Still in surprise there. We can work together to reach out to the all 7 sub-counties. Though even the 3 sub-counties, we are not 100%, but we still need to scale up. That is like a positive idea. Why was CSTOC not rolled out to all CHVs since you're the champions? Yeah, wow. Yeah, I know we are champions in CSTOC, but through the management of the sub-county and the county, we are able, with the partners, to make sure that CSTOC is rolled out to all the CHVs, even to the, because even the CUs that we had when CSTOC started, there was like some kind of attrition, and we did like mentorship to the 3 new CHVs who are coming in. So we really championed, and all those people are reporting even now. So it's easier for us to do that in the whole county. Thank you so much.
Asante. That was a mouthful for Turkana. He deserves a clap, surely. So many questions for Turkana County. Now, there are some online questions. Ken is not in the room right now, but maybe I'll give this to Yasmin. How will InSupply ensure data visualization continues after the end of the project? Ken already answered it, in some ways. Do you want to say a word or two around that?
It's an online question, so I'll try and raise my voice. But we have made sure that the ITT is open access and free for everyone. So anyone who has the link, and it'll be available on our website, can go in and see their own data visualized in the way that we've done it on the ITT. And there should be the IT portal there. So it should not be
Okay. Is open access. All right. So the ITT is open access and people can access it. What is HP2D, George? In exactly 4 words, what is HP2D?
HP2D means hybrid paper to digital, basically taking a picture and sending the green button, your report is done.
Excellent. And there's a demo on the solution tables right there being piloted in Loima. So some of these counties, I know Dalmas is familiar with them and they should be addressed. This came through the online portal and was specific to George and to Turkana again. Ideas and gaps that we've talked about, not new. We've talked about this a bit already. How do we get our stakeholders from the political arm involved in healthcare? All right. How do we ensure that these acts are passed? How do we get into the county budgets for healthcare to be prioritized at primary healthcare level, at community level? Resources, we need to budget for funding from the get-go. And when our budgets are in place, then it's about the spending all the way to community. When we put in an order for that facility, we put in for the community unit. So these are things that are already being done in our counties. Updated curriculum. So this was one of the ideas that is there. Whenever we update something, ICCM training is going on, let's update it and roll it out for everyone. Opportunities, some solutions. I'm going to take us quickly through this. CSTOC does not need a smartphone. Again, Ken said this. We are creating solutions for the user, we're creating not users for the solution. So the solution has to fit the user. I only have a feature phone, report on your SSD. There's no internet connectivity, report on your SSD. And there's all that's available. There are different digital tools at community level. How do we incorporate all this? Let's not be a me too. Let's see how we integrate those. And that is also work to us as partners. How do we move this forward together? That results in better data control, improved reporting. Co-creation of this process is going to get us at a different level. Indicator tracking tool, appraisal forms. I had Nairobi talking about this. And we monitor the targets and keep improving. Other opportunities, let's recognize our CHVs for the positive work that they are doing, all right? Because they are the face of primary healthcare for us all. Visibility of commodities at community level, and at the press of a button, someone said he sits in his office and he can see what's happening. Someone said he knew when Ken was showing him the ITT that those facilities had not reported because the impact teams had informed him that something was happening or not happening. Child learning sessions, how are we supporting our CHAs? There's a lot of delegation that goes to them. How do we support them? Yes, we talk about CHVs quite a bit. What about the CHAs? Let's keep them in mind as well. Erratic supply of commodities impacts primary healthcare? Yes, it does. How do we make that different? There are ideas that have come around the room. Let's see how we can adopt those. Commodity availability enabled by CSTOC. We can see better what's happening at community level. I want to give a minute to Miriam. She has a few comments from around the room. Yeah. Thank you, Miriam.
The first one is for Nairobi, where they are saying tea and snacks, very good motivator for CHVs or for the meetings. The second one is, I love the learning packages opportunity. Upload some of the modules, if not all, in the MOH Virtual Academy for visibility and usage by more counties. Thank you.
All right. Any other comments around the room? I can see some sticky notes. Yes.
Thank you. So mine were just one or two questions or comments as you may describe them now. The first one was, how have donors and partners mitigated political risk that has hitherto forestalled or interrupted health products and technology supplies, e.g. of FP commodities? Somewhat linked to that is, what are donors and partners doing to ensure sustainability of program commodities, that is FP, vaccines, antimalarials, and nutraceuticals? A comment there, one cannot give what or no manage what they do not have. How can the public sector in health leverage on private health sector resources, platforms, and experience to promote health program item supply chain sustainability?
Okay, so I like that Amos is right next to you for him to take a crack at the first two, and Yasmin as well. I'll try the third one. So public-private partnerships. Yes. And Judy has a comment as well.
No, I am pointing at Dr. Macharia because it's a very comprehensive health product and technology strategy.
Mm-hmm.
It operates most of those things. So give a comment to that as well.
Thank you so much. Dr. Macharia will give a comment after Amos and Yasmin give a few comments. Thank you.
I think the first comment or question from my neighbor here is, what are donors and partners doing to ensure sustainability of program commodities? That's vaccines and other family planning and antiretrovirals and others. I think I'll take the side of vaccines. What partners and donors are doing to ensure sustainability of such and of course, try to discourage dependence on them, is we are trying to encourage governments or programs to plan using actual targets. What are you targeting to do? If I can narrow myself into vaccines, you go into a micro planning starting from the lowest level. Somebody here mentioned of bottom up. Have those targets set from down there until the national level. Then you can focus and see what will be requiring in the next several years to come. Then look at what is available. You have been depending on, for example, Gavi for so long, and Gavi may very soon be pulling out. What happens when Gavi is not able to support the procurement of vaccines? Then you involve the government, Ministry of Finance, Ministry of Health, make sure that they start looking for resources to fund what is likely not to be available when the donors pull out. I want to give an example of those of you in this room. We have been running short of measles. We have been running short of BCG. These vaccines that are bought by the government. But for the past 2 years, you realize that those shortages are not there. Why are they not there? It's because the government has been involved. The Minister of Finance has been involved in planning. The Minister of Health has really involved the Minister of Finance, so that a budget is allocated for that specific item. And therefore, you can see the fruits coming out of that. So even if other donors again pull out with proper planning, looking ahead on what's happening, then you are likely to solve some of those problems. Maybe somebody else can help.
Thank you, Amos. So again, it's the involvement of all stakeholders in making health a priority. All right. Yasmin, then Dr. Macharia, kindly.
Great. And I think Dr. Macharia has a lot to say, so I'll keep mine short. My question was, how have donors and partners mitigated political risk that has hitherto forestalled or interrupted HPT supplies of FP commodities? I think it's a great question. All I can do is maybe comment a little bit on what I've observed, but not being a donor myself, please take this with as my opinion. What I have seen is an increased partnership approach with governments to try and say, is there a way we can meet you halfway? So for example, if you are able to put X in your budget, can we put Y in the budget? Can we match it? Can we do procurement that is based on some kind of data-driven forecast? Is there demand planning? So I think one of the examples we heard about in a different meeting was many years ago, Kenya had a budget line for procuring family planning commodities. And sadly, that got lost along the way. So I think there's attempts now to revive that concept, that commitment that Kenya was one of the first to show. And there's different leverage points that I think we see donors trying to do, one of which is promoting that joint ownership and partnership.
Right. Thank you, Yasmin. Dr. Macharia.
Thank you very much. I can see there are a lot of issues that probably we need to address. One issue that seems to be coming out strongly is an issue of leverage of private sector resource platform. And maybe for those of you who have not had the chance of going through our strategy, that is a supply chain strategy for division of health product and technologies. Issues of private sector partnership is very, very well articulated, because we realize that we cannot achieve universal health care without utilizing every available resource. A case in point is the rollout of anti-malaria, that is AL, through the private pharmacies, whereby the ALs are available at a subsidized rate of 100 shillings. And that has worked out very well, because in your local pharmacy, you walk in, for as long as you have a prescription, the price is known. While the actual cost of AL is well above 400 shillings. But through donor funding and private partnership, utilization of private partnership, the product is available at your local pharmacy. I think because of the issues that seems to be posed to DHPT, we are a very young division, but with an elaborate pathway of where we want to go. And we are coming up with the programs that are going to support. There is an issue that was raised about donor project pulling out. We have already mitigated that. We are actually planning and doing budget, and we are ready to take over. There before, issues have been approached in a we have not been involving the donor, the Ministry of Health at the time of exit. But now, where we are, any program which is coming to an end, we are ready. We have done quantification. We have done budget. We have forwarded the budget to Treasury for consideration, that this is a match that Treasury needs to put aside in the event a donor pulls out. There is the issue of consolidation of all quantification data. If you look at what has been happening in our country, every donor picks a product, does quantification, come up with figures which are not related to anything. So what we have decided as a division is to consolidate and do everything centrally, because a donor is providing AL. That is only one of the many HPTs which need to be provided to the people of Kenya. Therefore, if you go to press all the media houses claiming a success story, can we sustain this country by supplying only one HPT? We need to think outside the box. We need to address supply of HPTs in wholesome. Yes, you're doing a good job to supply anti-malaria, supply anti-TB, supply HIV products, but there are many other products that need to be put into consideration, quantification, so that we see and forecast. This is the amount of money that the country needs. In the event tomorrow Bill Gates withdrew from the HIV program, what would happen? We would go into a crisis. I believe from where we are, because we had not done that kind of quantification and identified the figures. If you look at from a national budget, HIV program takes an equivalent of 75% of our national budget. What would happen if they withdrew tomorrow? So we have already started mitigating and telling Treasury, this is what is going to happen. These are the scenarios. And in the event that happens, we are ready and we are set. Our prayers is it does not happen tomorrow. We would wish that it takes a few more years, so that we complete the budgeting process. It's unfortunate that power has gone, and I have no contribution into that process.
Did you plan for the power outage?
No, because the issues that we are talking about are real, and sometimes it is not very easy to tell Kenyans the truth, that this is where we are, this is what we need. But my prayer is we are going to get an engagement so that we take you through what DHPT are doing. I hope we are going to get some financing so that we have a sitting with all the counties so that we talk about these issues because they affect everyone. Initially, when devolution came, there was a feeling, oh, we are self-sustaining, but all of a sudden we have realized that there is need for working together with the counties because we are not competing with them. We are complementing them. Where there are gaps, we are there to support you. If we get a donor who is willing to do something with the county, we'll shadow them to you because we are not implementers. You are the implementers. Therefore, there is that clear understanding that anything about implementation should be handled with the counties, not with the Ministry of Health. I believe we will get another chance to articulate the issues because they are many, they are heavy and weighty. Thank you.
Thank you so much, Dr. Macharia. Yes, I can see Judy clapping. That has shed quite a bit of light. There is another question to Dr. Macharia and one to Yasmin. I don't know if Yasmin has read hers and can answer. Or yes, please, Dr. Macharia.
There is a question which have been brought to my attention, and of course, it is the issue of KEMSA and KDF. Really, I truly would not be the best praised person to comment on this because a decision was made at cabinet level. No information has been communicated down. Therefore, everything is being held up there. But the reassurance that we have had is KDF are taking over KEMSA for a short time to normalize the institution. You know, the consumers, I believe, you know, the experience that you have had with KEMSA in the last 6 months have not been very nice. You are aware that the feed-in rate was at 18%, which was, it's not anything to talk about in this country. The turnaround time was 46 days for an order, which is also not very nice, because we're imagining if you order a product today, you receive it 1.5 months after. That is not very nice. Of course, the loss of product during transportation. There are also issues of damage of product during transportation. And of course, the other way, we blame KEMSA so much. There is also the other downside of it. The counties are also not paying KEMSA in time. So there are all those issues which needed to be sorted. The reassurance that we have, KEMSA is going to revert back to civilian operation. That is the reassurance that we have. Anything beyond that, I don't wish to be quoted. Thank you.
Thank you, Dr. Macharia. And I also put a full stop on that one. Now, we are going to close up this session. I see Ken picking up the mic already. Aha, he's answering, he's taking this question. Thank you. Kindly read it out from the audience.
Will we get the revised SOPs following the improvements of the app? I think the person is referring to from the initial time that we gave out we developed the standard operating procedures to guide the CHVs and the CHARs on using SysTalk. There have been some developments that have been done. So in short, we acknowledge that we have updated the SOPs. We're in the process of arranging on how we print and deliver them. So they will be delivered at county level, and then the county will be able to arrange on how they go up to the CHAR level. I think that is straightforward.
It is straightforward. So with all the updates, all the developmental evaluations, all the waves, all the improvements will be consolidated now. And as part of sustainability and handover, that will be given to the counties. Asante Ken. Thank you everybody for that session. The doors are still open. We are still online. If anyone needs to type in questions, please type them in and we'll be sure to get back. Now, I'm going to Hand over to you, Ken.
Yeah, thank you.
Asante sana.
I normally like dealing with the easy parts. So I'm back again. Can you guess why I'm back? Can you guess why I'm back?
And recognizing people?
Oh, yes. So for me, I'm a believer that good performance should be rewarded. And I've told you, no one will complain that you talked about them behind their backs. You talked well about them. No one. So even during tea, if you say the nice things about me and I get it, no one will complain. So in that regard, we really want to, the emphasis that we've given, that impact team is an approach. I normally make this joke. And someone from, I think, was it CIA, who confessed that they have used some of the skills that they've learned, like in organizing for meetings, the organizing auto, they have taken it even in their committees outside the health sector. So I always tell people, impact team is an approach. We have applied it in supply chains. It is proven, it works everywhere. And one of the things that we normally emphasize is regular meetings. Meetings happening regularly. I mean regularly. Regularly means it is predictable. It can be once a month. It can be quarterly. We encourage once a month because data comes on a monthly basis. So you're able to review that. So there are teams that have worked tirelessly to ensure that they have been meeting on a regular basis, and we reviewed the data for the last 12 months. So we acknowledge the consistency. The key word is consistency. We acknowledge the determination. We acknowledge the passion. We acknowledge the teamwork. And everything that ensures that we are using data to improve our performance. So without further ado, allow me to recognize the following teams for doing such a great work. And the first team, whom we call the second runners-up. You know, I used to love music festivals. I didn't know the meaning of second runners-up, first runners-up. So the second runners-up means they are the third. When we compare everyone among the nine counties, the second runners-up go to, their governor needs to remember to hear this. They reminded us. You can now guess. So we recognize from Nyeri County, Nyeri South sub-county, and we want to give them, if you don't clap for them properly, I'll go back with this. By the way, this is not just, so I'll welcome, please, sorry about this. I'll welcome Dr. Tafadhali, sorry about this. The name has disappeared, so I'll just get Dr. Fatia, please come and award this session, please. Yeah, you'll start with this. So you are awarding Nyeri South for outstanding performance, ensuring that they are consistent in meeting, and please continue. As we welcome the second team, I'll say one of the key tenets and key principles of impact team is that people meet knowing what they are going to discuss. Is that a good thing? Should it stop now that in supply has, maybe when the project is coming to an end? Let me ask you, is it good manners that when you are coming here, you knew of the agenda? Is it good manners that when people are meeting, they know, so that they don't discuss AOB for 45 minutes and then the main agenda is discussed for 15 minutes? That is impact team. So for that regard, in that regard, we want to welcome all the way from Wajir. Please join me in congratulating the team Tarbaj from Wajir for being the first runners-up. And we recognize the challenging conditions in Wajir, and they will be, as they are meeting, please remember to turn on the fan so that the environment can be much easier to work in. Thank you. The heaviest award goes to the most outstanding impact team with the highest score. And again, you can guess. Whoever gets this right gets chocolate. Please. Get me the chocolates, chocolates, chocolates. Oh, sorry. They look like coins, but they are actually chocolates. So someone has said tarbaj. Another person is saying, why if we just think about Wajir? Aren't we having Endebes? Aren't we having Kibish? Okay, the most outstanding team for the impact teams, the award goes to none other than the Wajir North. So please, even as you take these awards, remember some of the things that we say, that there must be action planning. You must conduct root cause analysis, yeah? And you must be able to do recognition, and you do what? Planned recognition. So thank you so much for that. I'd want to just to acknowledge each and every person who is viewing online, and we acknowledge, we appreciate. There are many and much more awards that we've already even gave out, especially in the scale counties. In Siaya, we had even people with umbrellas to take them through. We have people. So all these awards will get to you. Last but not least, we recognize the work that we've been doing with CHV. So we may not have the adequate time to present the certificates, but all the CHVs have certificates that will arrange on how they come to you. They are actually there. Maybe you can just show so that they know that it's in their interest of time that we are not giving them out. But for all the CHVs they have, in all the counties, they have those awards. We also have awards that we are recognizing the work that we've done with the national team, and we have given them a token of appreciation. Above all, remember, impact team says low cost or no cost recognition. Like it costs us nothing to clap for everyone. Can we clap for everyone? Thank you, thank you, thank you. Karibu sana. Judy, back to you.
But I have no authority to close this meeting. But I want to get your feedback just one last time. Yeah. And I want us to go to menti.com again. One last time we go to menti.com. We just want to get your feedback about this event. We have interacted about closing out some of these projects, and we want to see, also recognizing our counties, sub-counties. We would have loved everyone to be here, but it was not possible. But having you as a representative, we want to know, how did that feel? So for our workshop evaluation, we will use code, someone to assist me here on the screen. We will use code 76441723. 7644. Okay, please. Okay, then can you fix it, please? 76441723. Just a minute. I understand there's a different code. Sorry for that. Just give me a second. The code that we will use is 1558, and it's on the screen. 3541. 15583541. I can see a number of people are already in. Great, more people joining. Yes, let's go ahead. Let's go ahead. We want to get as much feedback as possible. Yeah. I see we are just 16, and we are more than 16 in the room, including our online participants. Let's participate in this. I promise if we get to 30, we can start answering the questions. We are 23, 7 more to go. What we are 7. There are people I don't see them on their phones. Mshamaliza. Okay, 26. Leslie, I hope you're responding. I see you've logged in now. Joyce, where is your phone? We want to see from your perspective what's worked well, what did not work well. Yeah, any recommendations? Okay, let's not get stuck. We are 29, good, thank you. So let's see what worked well. What worked well during this day? Please put in, I think you can put in multiple responses. I see panel discussion was good. Wonderful experience sharing, the meeting agenda, presentations by county teams. The venue was very nice. Excellent facilitation, good recognition. Wow, those are excellent points. Problem solution stations, those were good. Award and recognition, the venue. Panel again comes up, venue. Feedback from counties, recognition of best performers, networking with others. I hope that was really useful for you. Thank you for those responses. We'll move on to the next question. What did not work well? What could we have changed? I think we heard from some presenters saying that at InSupply, we are responsive. We don't fear failing. So if you tell us we failed in this way, we will try and correct it next time. So please give us that feedback for us to improve. I see seating arrangement. It was crowded. Time management. Yes, we'd have loved to see greater national involvement. And yeah, I'm with that person for Arusa Mosas. They felt me. Someone would have wanted us to invite CHVs and chairs. Okay, the whole design didn't work. It was too narrow. I see late data bundles disbursement. I guess that's coming from the online participants. Make the sessions longer next time. The logistics not explained, that's to do with the per diem. We apologize for that. For those who didn't get enough information about that. Then there was not enough water. The network, yes, the network was horrible. We should mention that in the feedback form. But thank you for that feedback. We'll keep reflecting on some of this. So the final question is, do you have any recommendations for us? Any recommendations that you would want us to consider? Watu wa Mambasani, tunaomba recommendations. Maji ya tumvi. Mombasa people are saying next time we go to them. Oh, please don't go. Okay. Keep doing what you do, good. Scale up HP2, I think that's meant to be HP2D. Yeah. And we could have done a better job with acronyms, I think. Yeah, because I feel that we just threw a lot of acronyms and people didn't understand them. Keep it up. I wish the impact team's approach to be escalated to other counties. Next time, invite futures, CHVs as part of the recognition. We acknowledge your recommendations. Thank you very much. At this point, and I see they are still coming, don't stop. If you have more, please keep them coming. This is an online tool. We will get all the feedback and we will respond to it. I think there has been a lot that has been said today, a lot of reflections, which we really appreciate as In Supply Health. For us, this was a celebration, a culmination of all the hard work that you have done. And that is why we put an effort to just try and recognize at the different levels. And we decided, let's engage with you as the leaders from the different counties. We've been engaging with the impact teams at the county, at the community, and they can tell you for sure, Dr. Salim went to recognize the community, yeah? So we could have done it at the community, but we thought you leaders can cascade it down. You realize that the awards that you're carrying today might not be your own, yeah? They may belong to Endebe Sub-County, Dr. Masibo, I hope salamu zitafika. Microwave na kettle zitafika huko. So, and find an exciting way to appreciate these people because they're the ones who do the hard work. And we've realized that motivation is key to performance improvement. We want to see this progress sustained. We want to see inflow of data continuing. We want to see better supply chains at the end of the day. And I think that will be my parting shot from the In Supply desk. So I would like to invite our CEO to just give a vote of thanks and then invite Dr. Macharia, who will give us the closing remarks and declare the workshop closed. Oh, sorry, before we do that, I realized that we had national participants who have actually done a lot for us today. Some of them left during the day because when they're in Nairobi, they have to run around and do many events. But we have a few who still remained behind. We'd like to recognize Dr. Fathia. Please give Dr. Fathia a bag. Tafadhali mpe Dr. Fathia makofi. We'd like to recognize Ernest Some. Simoni hapa, but he's somewhere around. If we can find Some somewhere. He's one of our CCE champions when we have implemented remote temperature monitoring, VARO, this HP2D that you're hearing about. They have really supported in that. We recognize you. And Dr. Macharia, who has stayed on to the end, we recognize you and appreciate you. Thank you. Please give a bag to him as well. Okay. Yasmin, over to you.
Thank you so much, Judy. And a big thanks to Judy, starting with my vote of thanks, who is really been so energetic and pulled us all together for such a great day today. But saying thanks to all of you. It has been a very long day, and but a very fulfilling one. I think I've learned so much from listening to all of you, and I really appreciate your active participation, your commitment, your passion, because you didn't just come to participate, sit down and listen. You came, you shared what you've learned, you really were committed to helping us and each other get better. Some of the comments, I've been tweeting a lot, some of the comments that I heard as part of the panel, but there's so many rich insights there. And I just want to remind us all how powerful we are. When we come together like this, we have so much knowledge and insight together. And I think, as Judy was saying, we look to you as our leaders and our partners to go back and spread this, because you have so much knowledge. We learn from you every day. We feel honored and privileged to have partnered with you. And I rarely come out to the field, and I wish I could do more of that. But I get so much insight when I talk to the team, and they've been with you in the field. When I occasionally come out, I always learn so much. So I think if we can stay committed to the learning, to the sustainability and to growing. There was a brilliant quote from Transoya, right? Sustainability is not just about the resources. Sustainability is about the attitude and the mindset. And I want to thank and recognize everyone in this room because you are leaders in that attitude and mindset and in that commitment for data use, for supply chains, for health, for all. And just give yourselves a big round of applause for all your work, not only today, but over the last several years. So thank you all for your partnership. Thank you all for your learning. We have recognized each and every county that is here, but I again recognize the recommendation we got. We count so much on the commitment of our volunteers, the CHVs, and they're not in the room with us. We hope some of them are online, but thank you to everyone who joined us online as well. I wish we could see your faces. I wish we could all be here today, but you were well represented in your questions, in your tweets, and hopefully your county leaders will come back and share some of this with you today. So a big thank you to everyone. And I can't end without thanking the InSupply team. They're a really great team. I know many of you have worked with them, and I feel very privileged to work with them as well. So thank you all so much. And with that, I would like to hand over to Dr. Macharia for the closing remarks.
Good evening, everyone. I didn't have a chance of saluting you in the morning because I came in a little bit late, but I did participate in the whole process. I've been given a very difficult task by the CEO of InSupply Health, but because of time, as much as the task have been given is difficult, I'll try as much as possible to take the least time so that we allow the teams who have spent their whole day here working hard to present to us the good work that is happening. One thing that seems to be coming out clearly, and it has come out clearly very many other times, is the involvement of primary health as an approach of lessening the disease burden in our counties. If you look at the structure of our healthcare system, we are more of hospital-oriented, whereby we wait for our patient at the hospital door when they get sick. But I am excited when I see counties, and especially a county, Turkana County, doing a very, very, very good and exciting job, knowing their landscape and how expansive their county is. But you can see the good things that they are doing, reaching out for patients from their residence or where they are to prevent them, to take care of the most common communicable diseases. InSupply Health did undertake a survey and supported the 4 counties. The results are exciting. It is my hope that this good work that has been done by the 4 counties can be replicated in the other 43 counties because of the biggest impact that it has on health of residents in those respective counties. Look at how easy it is to implement the CHVs, the volunteers, because We have thought all this time that we needed a trained personnel to reach out to communities. But now, here we have a volunteer. Even if you talked about a stipend, how much can you spend on that community health worker? The least that we can spend on the lowest kind of health worker is 25,000 going to 30,000 a month. And when you look at the impact vis-a-vis the input and the people they are reaching out, the impact is enormous. We needed to have done this yesterday, not today. Because partly why our country is going into disease outbreaks is because of some simple things that we can prevent at the local level. I am excited in the efficiency that this has brought up, and the mere fact that you don't have to rely on internet, which has made all of us very lazy. If you don't have internet, the first complaint that I had, there was no reliable internet, and it made so many people uncomfortable. Try and imagine what our CHVs are doing without use of internet. We have become slaves of things that we can do away with. And that innovation, this is what our country needs, because from the comfort of our offices, we think that we can only move things when we have internet. We need to move away from that. I feel that what In-Supply Health has done, they have done a good job. We are coming in a little bit too late. We are not complaining. We are not accusing anyone of anything. Remember, those who have been following what has been happening, in the last 2 years, nobody knew about DHPT. We were a small unit relegated in a prefabricated part of Afia House. But then, over time, we needed to assert our position and on the relevance of health products and technologies, because you can't talk about a functional healthcare without talking about HPTs. The uproar in our country is we don't have enough of HPTs. We are not budgeting for enough. Once the HPT supply chain is interrupted, like what happened in the Kempsam, you can hear the noise. Therefore, just reinforces the fact that HPTs plays an important role in our healthcare system. Therefore, when we did our strategy, and for those who have not received a copy of the strategy, we are going to make arrangement. You can liaise with me. We are going to give you a copy for your file, a copy for your library. Even if you don't get it today, you can give me your mailing address. I'm going to mail it to you. Those who need a hard copy, those who need a soft copy, I'm going to provide. That gave us prominence and relevance. Therefore, we were upgraded from a unit to a division. And within less than a month, we also got upgraded from a division to a department. And we have the promise by the close of the year, we are going to be elevated into a directorate so that we address those issues related to HPTs. Therefore, In-Supply Health, I am not complaining that sometimes even if you wanted to engage with us, you didn't know who to engage. But now, for any issues related to HPTs, we'll be at the center stage, and we will help you because we have a national strategy to implement any future project related to HPTs. The counties represented, it is very exciting to see what counties are doing, and especially counties like Saburu, Turukana, Mandera, and Wajir. Because you look at very many other counties, because we know what is happening, there are a lot of problems, real lot of problems. Sometimes a good act like what you are doing cannot take place because of a lot of infighting. Maintain the good work that you are doing. Remember, what you are doing it for Wajiko and the people of Kenya. If every county replicated what you are doing, then half of the problems that we have in our country would be addressed. Going into the future, we are planning to engage all the 47 counties, take you through the strategy so that you understand we are here to complement the good work that you are doing. Anytime you get stuck, don't hesitate giving us a call, paying us a visit. We probably could have solutions of some of the problems that you are encountering. And I know the day has been long. I was not, I don't want to claim that I was given greetings by, like the politicians do. I was not given greetings by any of the bosses in Afia House, but if you give me greetings, I'm going to take to them. And I'm happy. This is only a beginning of our engagement. We are going to engage further. When we call you, please turn up because there's a lot that we can do together. And with those few remarks and very many remarks, I declare this one-day meeting officially closed, but the engagement should continue. We are not closing the engagement. It's only the meeting, today's meeting. The engagement should continue. Let's continue talking to one another. That's good. Thank you very much.
Thank you. Thank you so much, Dr. Macharia, for gracing our occasion and for those closing remarks. I think I don't want the day to go by without living up to my promise. I urged you people to tweet, retweet, and tweet again. So for the ones in the room, I see Hanif Tafadhali, mpe a bag of chocolates. Let me see if there's someone else here. Isaac Jewa. Yes, Isaac and a bag of chocolates. I think the rest are not here, but we can, Dr. Maore, can we take a bag to be there? Yes, please. She's been tweeting, retweeting, and participating online. Yes. We recognize other online participants, Jerry Karaoke, Lynette Okoth, who else? Okay, those are the ones I was able to get. Thank you so much to the online participants for staying patient, for your hard work, and even you who came here, we really appreciate you. I'll ask someone to our Muslim brothers or sisters, one of them to close for us with a word of prayer so that as people depart, they may have journey mercies back home. Any volunteer, please? Thank you. And if you feel you cannot carry your big microwave home or to your county, just be in touch with us. We will see how to get it to you. Sawa? Even the other awards, please, don't worry about it. Thank you.
Thank you. Let's pray. Bismillahir Rahmanir Rahim. Alhamdulillahi Rabbil Alameen. Ar-Rahmanir Rahim. Maliki Yawmiddin. Iyyaka na'budu wa iyyaka nasta'in. Ihdina as-sirata al-mustaqim. صراط الذين أنعمت عليهم غير المغضوب عليهم ولا الضالين آمين.
Thank you, everyone. Please feel free to take tea before you go and interact with us more.
Online. This video is going to take us through navigating the Impacting portal. To access the portal, simply key in www.acdatause.org. That is www.acdatause.org on your browser, then press enter. To log into the portal, key in your username and password, which will be provided to you by InSupply Health. In case you forget your password, simply click on the Reset Password tab. Enter in the email used to register, then click Submit. An email with the reset detail will be sent to you in due time. Once on the home page, click the Learning Packages tab. The Learning Packages option will appear as shown. Next, select the learning packages you'll want to learn by simply clicking on the View Training button. Once you select the View Training button, this will direct you into the course. To begin learning, click on the Start Course tab as shown. When you pause your learning and need to resume from where you left, or need to go back to the previous section of your learning, use the scroll bar on the left as shown to move up or down. At the end of every learning package, you can access additional resources by simply clicking on the resource link provided of the resource you want. To get certified and reinforce your knowledge further, click on the Get Certified tab, which will direct you to the Google quiz page. Once on the page, click on the respective course tab. This will direct you to the Google form for the test. A certificate will be provided once you attain a score of at least 80% in your test. You may retake the quiz up to a maximum of 3 times. After completion, you will receive your results through an email and a certificate shared after. Once you are done with the learning packages of your choice, you will go back and access other learning packages, which include Organizing Auto, Beta Problem Solver, Data with Diana, and Supply Chain Sum. For more information, kindly visit our website at www.insupplyhealth.com or email us at info@insupplyhealth.com.
InSupply Health Limited, transforming lives by co-creating innovative and sustainable solutions for healthy communities.